with the academic track, rightly said by Akshay. And good to see you, Dr. Priti and Dr. Sonam. We are missing you, though.
We are missing it too. Hello, everybody. Good afternoon.
So Dr. Priti Uday is a oculoplastic surgeon practicing in Chennai, DRR Hospital. And Dr. Sonam Nisar is practicing in Shankar Netralaya, Chennai. So very soon we'll start with the session. And I hand over the mic to the moderators, Dr. Harika from Visakhapatnam and Vijayawada, sorry, and Dr. Vipul Arora is a senior oculoplastic surgeon in Uttarakhand from Roorkee. Over to you.
A very good afternoon to all of you, and I welcome to the aesthetic session. So I request Sadhu sir to please chair this session. And our first speaker for today is Dr. Akshay Nair, who's an enthusiastic and prolific oculoplastic surgeon from Mumbai, and he's well known for his exceptional videos on the online platforms. So today he'll be speaking to us on the beauty lies in the eyes of beholder. Over to you, sir.
Thanks. All right, so although my talk is not technically in the aesthetic session, it's about a molecule that we use so much in aesthetics that I think that's why the organizers felt it fit best here, especially given the theme is twists and turns in oculoplastic surgeries. I have no financial disclosures relevant to botulinum toxin. That is the focus of my talk here. I think I'm preaching to the choir when I talk about botulinum toxin having multiple cosmetic and functional indications, which all of us treat fairly regularly. While, like any other treatment, botulinum toxin comes with its share of possible and potential complications. Used around the periocular area, ptosis and diplopia, based on the areas of injection and the zones of injection, zones of diffusion, can be caused by injecting botulinum toxin. While correcting strabismus, it can cause hypercorrection, which is transient, and of course, local bruising, swelling, and headaches have also been reported. Asymmetry in the two halves of the face where they have been injected can also be seen. We have one such complication that I'm going to discuss today. This is a 49-year-old female who was diagnosed and was a patient of blepharospasm and was being treated with botulinum toxin. She received Botox in both eyes, given by her neurologist who had been treating her. During the injection, she complained of pain in the left eye, but she was reassured. She had a little blurred vision the next day, and she noticed that the eye was drooping a little bit from the fourth day of injection. She presented on day 7 with ptosis and reduced vision of counting fingers at 2 meters. And then you just lifted up the ptotic eyelid, and we could see a big blotch, a subconjunctival hemorrhage. But the shocking part was what we saw in the eye was dense vitritis. There was significant vitritis for which we had to even go out to the extent of advising vitrectomy, because this for us looked like an endophthalmitis. However, she refused any sort of injection or intravitreal injections, prompting us to treat her orally with ciprofloxacin, prednisolone, both orally and topically, along with homide. She was reviewed periodically, and finally, oral steroids and topical steroids were tapered over 6 weeks. And at 6-week follow-up, she was 618 with N10, and there was vitritis. So now we did an OCT angiography. You can see in the superficial capillary layer, there is hypoperfusion, but it's in the deeper layer that the area of hypofluorescence and hypoperfusion is very, very prominent. Additionally, there is significant retinal thinning, photoreceptor damage, and complete loss of foveal contour. At 6 weeks, the vitritis had resolved, but you can see that there is sclerosed vessels, and you can see the area of perforation which is sealed on its own. At 6 months, there was no change. So in patients where we are injecting botulinum toxin, especially for an indication like hemifacial spasm, the key is to know where the right sites of injecting are. Now, as you can see here, it is the pretarsal orbicularis where 2 sites have been injected. You can see those little blebs raised, and this is the third one being raised. It's important to know the orbicularis is divided into 3 parts. There is the pretarsal orbicularis where we've injected. There is, of course, above that is the preseptal orbicularis, which we always avoid. not only because there is no hard structure like a tarsus there, but also because anatomically behind that lies the orbital septum, and through which the fat can easily diffuse through. The Botox can easily diffuse through and cause ptosis. In this case, however, what seems to have happened is that the Botox went through the eyelid, through the orbicularis, and the injection was injected into the retina, the vitreous cavity. So if we look at literature, actually studies tell you that botulinum toxin by itself is non-toxic to the retinal tissue. However, high concentrations have not been studied. We know botulinum toxin inhibits acetylcholine release. Now, this acetylcholine could also potentially disrupt retinal neurotransmission, also the retinal vascular tone. And finally, we do not know that while the Botox itself may not be an antigen, what we use in India is not bacteriostatic, preservative-free saline for reconstitution. So there could be some preservatives in the reconstituted fluid, which could also be a allergic or a hypersensitivity stimulus. The OCT clearly shows ischemic damage, which is irreversible. So there is an inflammatory mechanism along with a mechanical etiology that could have induced this kind of inflammation almost on an endophthalmitis level, a sterile endophthalmitis, if you may. So this is of course not isolated. There are previously 5 such published cases of inadvertent intraocular botulinum toxin injection, as being the 6th such case. So to summarize, inadvertent intraocular botulinum toxin is a rare complication. The key lies in early recognition and prompt action. One of the factors in this case that led to a permanent visual damage was the patient reporting almost a week after the injection, because that can actually potentially cause irreversible structure and functional damage because of inflammatory mechanisms that we've already discussed. The key is, of course, in careful technique to make sure that you do not end up having a situation like this. Thank you for your time.
That was an excellent presentation and a really rare case, Akshay. Can I ask a question?
Yes, please, ma'am.
Yeah. So what I now go back to think is that now if any surgeon experiences something like this, like increased resistance, what should we advise the other specialty people, whether they should do a vision check? Because usually one eye, little bit loss of vision, the patient also may not complain. I think in this case also the same thing, the patient complained only after 3 or 4 days, right?
So actually the patient recounted that immediately while during the injection, she complained of pain, but that was being perceived as pain of the injection itself on the eyelid rather than eye pain that she actually had.
Yeah.
And that's why it was a little difficult for her to, and also I think the other specialties could also be sensitized that, hey, it is possible that as outlandish as it sounds, it is possible that it can happen, because it probably, when we spoke to the neurologist and explained what happened, they were quite surprised that it could even happen. So yeah.
Yeah, and also I would like to reiterate here that we should give a good contact number to the patient. Many a times the patients can't contact the injecting surgeon very easily. And all these symptoms should be told to the patient that if you have pain, it is a significant symptom. And
Right.
they should report that, I think. Very nice case. Thank you.
Thanks, ma'am.
So one more query. So usually the pain at the site of injection, some surgeons do mix reconstitution. They use distilled water instead of this normal saline. So in that case, in spite of knowing that some surgeons some injectors still use, and they anticipate that pain maybe because of that, and they just let it go and they won't follow up the patient. So what is your intake on this?
I mean, I think it's almost borderline criminal to inject Botox with distilled water. We discussed that in the morning because like Dr. Shubhra had mentioned, the pH completely changes, making it very, very painful for patients. It becomes an acidic injection. So I think off the bat, even the insert of the botulinum toxin, the paper mentions clearly that we need to use normal saline. So I think every injector should know that, and I think rather than anticipating this as a complication, it has to be prevented. Pain has to be prevented by telling them not to use anything except normal saline for reconstitution.
Granted, saying that that's okay, that little pain can be tolerated by the patient. That is how I got to hear from 2 injectors. So
Wow,
that is one
okay.
significant point of take.
So thank you, sir, for a nice presentation.
Thanks, sir.
I think if there are any other queries, we can take them. Anybody want to ask anything? I have a query, sir.
Sure.
If this patient had presented earlier, say within the first 24 hours, what would be the management?
So in this case, it's difficult to go back and say what could have been, but at least one of the things that, lifting up the eyelid, once you see a subconjunctival hemorrhage, you know something has gone in. So by nature, by training, we are ophthalmologists. So it's not that difficult to pick up and dilate the pupil indirect and see. And I think we would have seen the retinal small, although it was self-sealing and it did not need barrage laser in this case, we would have identified that, which has been identified in all the previous 5 cases where there was intraocular injection. So we would have seen that, and also prophylactically started the patient on antibiotics and steroid and told them that, hey, this is a clear complication and we need to. Agreed, in this case, the patient refused surgery, but possibly an early vitrectomy if we saw early signs of inflammation at that point.
Actually, I have a question. So, for the interest of the audience, how can somebody inject pretarsal and hit the conjunctiva and sclera, and patient not having pain at that moment, and finding that that this happened at the moment of injection? Was that a late onset presentation from the patient of pain, or it was immediate pain that the patient perceived and it was overlooked? It was overlooked. So patient clearly said that they had pain. So also the patient did not get a pre-tarsal injection. It was a pre-septal or they injected above the tarsus. It was pre-septal. It was pre-septal. So that means the injection site was wrong. Okay. And so pain was reported immediately, but it was the patient was reassured saying, this is perfectly normal, don't worry. And the patient was, this was not her first Botox. So she knew the kind of pain that is expected and how this was different. But I think there was a delay in reporting for a follow-up as well.
Akshay, it was a wonderful presentation. And to me also, I think before this presentation, I would have, in enumerating the possible risks of Botox, I would have never said loss of vision. Yeah. So now we know that though it's like 1 in crores, but it is possible. Yeah. And as the part of pain was being discussed, yes, as you rightly said, pain is there, a bit of this is there. It is always subjective. The patient is somewhat very tolerant to pain, some are not. Some even scream during a normal injection site is given. And if there's a slightly more pain, sometimes we also say, it's okay, you are fine with it, and today you are feeling more pain. Yes, we should not ignore. Now we know. Being ophthalmologist, I think this would still be rare. Was it injected by the ophthalmologist? I forgot. Neurologist. So this is very important because the landmarks are much more clearer with us, not with the dermatologist, neurologist. Anyway, they don't inject much around eyes, but nowadays they have started moving towards into the eyes and hemifacials and blepharospasms. These type of presentations, I think, should be made much more commoner in their field so that they are restricted to their facial aesthetics and not venturing into anyway a smaller field which we have for ophthalmologists. They should know that it's not only the droopy eyes that they can lead to, but loss of vision. And then I think that's very important.
It's been submitted to a neurology journal as a case report.
Wonderful. And I would suggest later to the dermatologist and many more you should. And it should be at least percolated down the line. Thank you very much for enlightening us as well.
Thank you, sir. Thanks.
Thank you, sir, for an excellent talk. So now I invite Dr. Sonam. I think she's ready. Dr. Sonam?
Yes, hi.
Yeah, so Dr. Sonam is a consultant at Shankar Nethralaya, Chennai, and she would be talking to us on fillers beyond aesthetics. Over to you, Dr.
Hi. Yeah, hi. Good afternoon, everybody, and thank you for this opportunity. And making this hybrid. So my topic for today is fillers beyond aesthetics. And we all know that fillers can be either autologous fat grafts or they can be synthetic. Most commonly, we have the hyaluronic acid fillers that we use here. So they are mainly used for facial rejuvenation and volume augmentation. But there are multiple functional causes and uses that the fillers have been described for in literature, such as for correction of lack of thalamus after facial nerve palsy, cicatricial ectropion, as well as eyelid retraction. So how do these fillers help for functional causes around the eyelids? Is mainly tissue expansion. They provide a mechanical support, and also they work as a spacer depending upon the type of fillers that you use. Hyaluronic acid fillers have been known to induce fibroblasts and cause collagen synthesis, hence giving a better support to the periocular tissue as well. So here is a 58-year-old male patient who had history of 22 months duration of facial nerve palsy. He underwent multiple surgeries for lack of thalamus and ectropion correction elsewhere. He also underwent multiple times lateral tarsorrhaphy as well as medial canthoplasty for the correction of lack of thalamus. However, as we can see here, this was his presentation. Mainly, he was troubled by lower lid ectropion as well as lack of thalamus. He had a very mild inferior corneal exposure as well. As we see here, we can see that there is almost a grade 3 ectropion. If you look at the periocular skin, also the lower eyelid, there are some cicatricial changes here which have developed over a period of time. Also, if we look at the lid margin very clearly, the lid margin is quite rugged and there's a lot of scarring because of multiple tarsorrhaphies that have been attempted in this case. So he initially refused any further surgery for ectropion correction. So going back, we thought about how can we give him a better outcome. So we went back, looked at the literature, and we thought that the fillers might actually be a good option for him. So we used the Juvederm Ultra Plus XC 0.5 cc fillers was injected along the lower eyelid. Where was it exactly injected was just in the suborbicularis plane. As you can see, these were the sites that we injected in. We gave him an option, surgical option as well, but he'd already undergone multiple times inverting sutures, lateral tarsal strip, and he did not want to go in for any surgical option at that point in time. So once we gave him the fillers, on the table, there was a fantastic correction. However, 2 weeks later, via email, this is what happened to the patient. He developed a lid abscess, and as you can see, after the pus was expressed, there is a little granulation tissue in the lower eyelid. You can see that the ectropion was well corrected. However, because of this, I was a little more worried that the patient might develop more cicatricial changes after the infection. He was started on oral antibiotics and we advised him warm compresses. At 6 weeks follow-up post-injection, this is how he was, and I was very happy to see him because his fillers had been retained there. His ectropion was well corrected, and he was also willing for another surgery for lag of thalamus correction. So this is how we managed him with an upper lid gold weight implant, and we can see that there was an improvement in the lag of thalamus as well, and the patient was doing fine. So, this was a case of cicatricial ectropion who underwent multiple surgeries managed with fillers, a non-surgical, minimally invasive and a safe approach. Now, here is another patient who's a 28-year-old male who had history of RTA, multiple orbital facial fractures. He'd already undergone orbital floor repair elsewhere, and he presented to us with this picture. He had an enophthalmus. You can clearly see there's a grade 3 entropion. There was a transconjunctival approach and a lateral canthotomy cantholysis that had been done for this patient. You can see there's a subtle superior sulcus deformity, lateral canthus surrounding, a little scar around the lateral canthus. When we clearly look at it, the lateral 1 to 2 millimeters of the lid seems fine, but the rest of the lid, there is a gross entropion there. So, we further retracted the lower lid and we noticed that there was a scarring all along the posterior lamina here, which is causing kinking and inward turning of the lid margin in that area. Now, patient refused any surgical intervention, but clearly, as you can see, he had multiple SPKs and abrasions on the cornea. So here again, taking into the consideration of principle of a cicatricial ectropion, we thought that let's try giving him some fillers. We explained to him that this would be temporary and we don't know how much it might really help because it was already about 3 months post the correction. So here the difference what was there was we injected very close to the lid margin and just pre-tarsal plane. That was a plane where the fillers were injected. Whereas in the previous case, as you see, it was injected much lower to the tarsals, like 4 millimeters from the lid margin. And here, as you can see, it was injected just in the pre-tarsal plane, as you can see in the picture here. This is an immediate response to the fillers, as you can see. You can see there is an improvement in the lash misdirection that you can see there. Also the entropion. This is a 12 weeks follow-up. The patient was very uncomfortable with the bulge that had been created. And we thought that we can resolve the fillers in this case. So we use a hyaluronidase injection. And this is a picture 6 weeks after resolution of fillers, which shows a fantastic correction of the entropion with just fillers. So yes, hyaluronic acid fillers have been described in literature for cicatricial ectropions. However, there is not a single case report that describes the use for the same in cicatricial entropion. So to conclude, it's a very non-surgical, minimally invasive, reversible procedure. How it works is basically by tissue expansion, giving a mechanical support as seen in the first case, and by releasing the scar tissue adhesions and working as a spacer as we could see in the second case. So, well, the twist and turns in this case was that first, in the second case, there was no literature report. I mean, there was no literature which states that it can be used in cicatricial entropion, but in canines. So, looking at that, we thought we can utilize that in humans as well. And in both the cases, the patients were not really willing for any surgical intervention at that point of time. Also, in the first case, the patient did develop a reaction and a lid abscess post fillers, which was not very good. He was managed conservatively, but I thought that maybe the fillers cause this infection. He might develop again a recurrence of the ectropion, but the patient is doing well, as you can see. So that's it. These are the two cases. Thank you. Thank you so much.
Thank you so much. That was an excellent presentation. Yes,
Thank
Dr.
you.
Preeti.
Yeah, that was excellent, Sonam. This always we want to do this, right? We want to buy time before you do any corrective surgery after any traumatic entropions. And this is a lovely way to buy time, basically expand the lamella and see after some time. If it recurs, then you can take them up for surgery. So at least 6 months you can wait either with 5FU or with these fillers. But I find that sometimes it's very difficult to get the plane because they are very, very scarred.
Yes.
Do you like select these patients or it's just a one-off experience?
Well, this is just a one-off experience for cicatricial entropion because the patient was just not willing. And as you see, it was really bad. We didn't want to leave him to come back with a corneal ulcer. So we gave him this option. I did give him an option of 5FU also, but this seemed to be more this thing because, as you know, post-trauma, we also have soft tissue loss there because he's already undergone a surgery. So I thought it would compensate for both.
And the choice of filler like XC we hardly use, right? It expands like anything, absorbs a lot of fluid. Would
Yes.
you like try something else or have you seen reports with other products being used?
For entropion, I could not find anything. But yes, for cicatricial ectropions, they have used they've used volumers for Wolfitz for ectropion, cicatricial ectropions. So yes.
Nice cases.
Thank you. Thank you so much.
So anybody from the audience here wants to ask?
Hi, Sonu.
Hi.
I just want to ask, normally we encounter lid retraction post transcutaneous approach in orbital floor fracture repair. I had one case with lid retraction, transconjunctival. I had repaired that case. So any experience in these patients who have lid retraction post transconjunctival fracture repair? So you will prefer, because they are not, after one surgery, they don't want to go for another surgery. And it was very early in the post-op period. And it was very unusual for me also to see these kind of post-op outcome, lid retraction post-transconjunctival. So any input, Preeti and Sonam?
If you see that, I think like Dr. Preeti said, we can give 5-FU injection if you're seeing within 6 to 8 weeks of in the post-operative period, and works fantastically well to release the adhesions. Another thing is, I don't really suture the conjunctiva unless and until I'm going all the way up till the carrying pill. We just leave it to suture, because what happens is sometimes if you suture the conjunctiva, sometimes it causes more scarring, and that can itself induce more of lower lid retraction in these cases. Dr. Preeti.
Yeah, actually, I'm a little wary of using fillers in post-op patients because the chances of embolization are higher because your vasculature is affected in post-op cases. Same thing, we see that in post-traumatic scarred areas. So you have to be very, very careful in using fillers. I think the principle is you're just everting the eyelashes just like you do in epiblephrons. And maybe it just buys you time. So if that plane is clear with less scar, you have not touched that area, you can try that. But my first choice is usually 5-FU because this is expensive also. The filler is also expensive.
Yes.
No, mine case was not entropion. It was just a retraction.
A retraction.
So I
But
don't
also
know.
you can 5-FU to expand the middle lamella, no? You have scarring in the middle lamella when you get a lid retraction. You can use 5-FU. That helps in the scar. And of course, even filler has been reported in lid retraction. It has been useful. It expands the middle lamella.
Yes. So I think immediate post-op, even I would use a 5-FU first to release the adhesion, soften the scar tissue, and see how the lid is being positioned. If it's not improving, then yes, fillers would be a choice probably after 2 to 3 months.
Yeah, thank you, Dr.
Thank you.
Sonam.
Thank
So now I would like to invite Dr. Shilpa Taneja. So she heads her own clinic, Face Aesthetic Center at New Delhi. So today she'll be talking to us on how small a small surgery can be.
Good afternoon, everyone. Presentation, please. Yeah. So as we all know, these small lesions, the xanthelisma palpebrum, are more common in females around 30 to 50 or 60 years of age, and they are cosmetically bothering, and people usually want them removed. And thus, such patients are referred to us oculoplasty surgeons, and they most commonly go to ophthalmologists first for the treatment. So this lady having the same problem, although the problem is not very large in magnitude, presented to an ophthalmologist and underwent a surgery. After surgical excision of bilateral xanthelismas in this case, patient had an cardiovascular emergency, and on 8th day, not because of the surgery, of course, but independent. And on the 8th day, patient, this is a reference picture because I don't have a pre-op surgical picture. Patient was referred to me. The patient presented like this. So this is the right upper lid, and this is the left upper lid, because the patient was being taken care of for something else. So the upper lids were neglected, I think, in the hospital. And this is how the patient was referred to me. So for that small lesion, which the patient was bothered about, the patient had developed this. I did debridement of the necrotic tissue, and a week after antibiotics, I undertook the patient. This is the picture 1 week after debridement. And then I took patient for reconstructive surgery. This is the picture 2 days after reconstructive surgery. In the right eye, I had to put a small upper lid epidermal graft there because the defect which was created was large. And this is 1 week post reconstructive closure. This is the picture 3 weeks post-op. And this is a 1 month post-op picture, how she looks now. This is just very recent, 3 days old. So I wanted to put up this case here at this podium to emphasize certain things, that whatever we may think, a small surgery is never very small. And we all know xanthelismas and how they are treated. The take homes, which I feel we should think that every surgery is a surgery. Post-operative care is very important, and a proper post-op care is mandatory. and excision and good closure is very important. And we all know this also, that this condition is commonly associated with cardiovascular ischemia. So I feel like after this case, I thought that if a patient presents to me, I should refer the patient and ask the patient to get tests done for cardiovascular fitness. Yeah, because the patient might not know and patient might be gradually progressing towards it. So this is one take home. And when the patient is undergoing, is hospitalized for some reason, the islets should not have been neglected, you know. So that's the small case I wanted to present and wanted to show. Yes, ma'am.
Oh, nice, lovely case. But what was the exact problem? Was there infection or just ischemia?
Yeah, infection, ma'am. Not ischemia in the lids. Not ischemia in the lids. Infection.
The infection did not resolve by itself. There was a defect which you had to.
There was a lot of necrosis in the muscle also, ma'am. And I want to emphasize one more thing. If I show the pre-op picture of this patient has ptosis as well. And I feel if this patient would have come to me, I would have advised her differently. So a specialized person, I think, can advise a patient differently. Along with excision of that small mass, I would have advised patient to undergo ptosis surgery also, if she obviously desires that surgery. So
yeah, that fight continues. But but now what I was discussing, I wanted to discuss and ask the other panelists also, is it an overkill actually to refer patients to cardiologists before doing xanthelasma?
yes, it is. That's why we never do it.
I can understand from your case, but we have done so many in so many years, and it is a one-off case. So, I mean, would the others also like to do that, or are we going to do?
No, ma'am, I feel we can just tell the patient that get your annual tests done.
Yeah.
Because many of them just don't get it done for many years. Let's say for 10 years, they have not gotten them done.
No, but the main problem there seems to be infection. It's not as ischemic.
Yes.
So was she diabetic, pre-diabetic? Because
No, she is not diabetic, ma'am.
So I think, I mean, the baseline tests of, like, sometimes in this procedure, we don't get any kind of test done, maybe just a random sugar. So a fasting PP, HbA1c, urine to see if there's any infection. So for all, at least this we can rule out an infection. But I don't think you can put up 40 or 50-year-olds and say, go get a cardiovascular
not
evaluation.
Per se a cardiovascular evaluation, a simple ECG or lipid levels. We usually order lipid levels in any case, but not all patients have low HDL or changes in their lipid levels.
Yeah, I think the take-home message here is to all the investigations, like we do for any surgery. Don't take it like a small case and not do the investigations.
Yes. And plus sorry, Akshay, you were saying something.
I'm just saying, there is enough evidence to show that xanthelasmas are associated with elevated basically hypercholesterolemia. But at the same time, the corollary that every patient with xanthelasma does not have hypercholesterolemia and vice versa.
Yes.
But a higher proportion of patients with xanthelasma have elevated or deranged cholesterol lipid profile as compared to the general population. So you are definitely right in advising a lipid profile. But I think I may be with Dr. Preeti in saying perhaps like a cardiologist clearance would be an overkill, but
not a cardiologist clearance. I never said it. Sorry, but a normal ECG or something, just ask the patient whether you have had your annual testing done this year, because the lesions are usually above 40 years of age.
Who did the xanthelasma excision?
An ophthalmologist.
Okay. Did they rule out the necrotic version of xanthelasma, which is very, very
so I don't have the pre-op
prognosis?
picture. I took this picture from the patient after the surgery.
I don't think it is a secondary infection to an initial surgery. I think this was much more happening to the lesion, because xanthelasma, though it may look smaller, can have an associated necrobiotic
component
with it, and which needs to be ruled out. And every xanthelasma which is operated, especially surgically, has to be sent for histopathology alongside the systemic evaluation, which has been already dealt with.
And I don't have any other experience apart from excision of xanthelismas, like I don't do lasers or.
So I have the largest series in the world for xanthelisma with plasma, and it is doing wonders, and it is non-surgical with no collateral damage, and the results are permanent. So excision is one part of it, but yeah, I think the case, what you have presented is not about ischemia or secondary infection. It's all about having a coexistent disorder in patients with xanthelisma, which is pretty common.
Shilpa, nice presentation though. I think you would not have thought that this small presentation would incite such a good interaction. So what I think you have brought few good important points. One is whether even a smaller surgery should be subjected to investigations, to a cardiac clearance, to, should you think that you are going to land up into a problematic situation. Once you say that every patient should have a yearly checkup, I would like to ask all my delegates and doctors here, how many of us have a yearly cardiac checkup? 1, 2, 3. So four. A yearly one for you?
Yeah.
You're not
Cardiac, no.
aged, I believe. So even we, being doctors, we don't get even, I say cardiac, I think most of us would not have a proper blood profile every year, even though some of us are beyond the age, which I would not like to specify. So one practical tip which I would like to share with you is, you should always advise what you think is right, but you may not get it done. So that practical or for medical legal purposes, you are not in a soup. So once you are taking for a procedure, because these are very minor procedures and most of our colleagues are doing it in like office procedures, your prescription should bear that advise such and such, all the investigations, profiles, viral markers, RFT, LFT and all before the surgery. But I verbally say you may not get it done. Generally it is okay, for yourself, but medical legally, you'll be correct that you have advised. Ma'am, for such a small surgery where they won't want to pay 5,000-6,000, they generally, yeah. Not warranted actually.
One more thing I'd like to add here is like we make the surgery small. I mean,
it is wise.
Just trying to say that you should charge properly for these patients and make the patients understand that it is a surgical procedure and it should be done in the operation theater. Because many a times it looks very small, but we all know when we excise it, it's a large defect, and then we need to close it well. And so therefore, at least for xanthelisma, I think we should do the investigations.
Thank you, ma'am. So
Thank you all
Dr.
of you.
Shilpa, for igniting a good discussion. Now I'd like to call upon our next speaker, Dr. Debraj Shom, who is the director of the biggest chain of aesthetic clinics in India, the Aesthetic Clinics. And today he'll be talking to us on temporal brow lips, what to do to get great results.
Thank you very much, Harika. Thank you so much for having me here, Vishal, and the UKSOS as well as OPAI. We are here, we are enjoying ourselves, and yet there are people there who are dying for our country. So it's a very difficult time for all of us. Before I start, I'd like to remember all of them, especially as an Indian and an ex-army officer's son. So Jai Hind to all of us. My name is Debraj Shom, and it's been a fantastic last few days in starting today morning when we were at the Everest Peak. And those were some wonderful hikes, which Vishal apparently had done a recce before he took us there. And then before that, a couple of days ago was Rishikesh, water rafting. And then we had some wonderful times with the entire family being here. We also had a spiritual time. There was the Ganga Aarti, which was happening in Rishikesh as well as Haridwar. So thank you for having us here. Now we're talking about the temporal brow reset surgery. I don't like to call it a brow lift. I like to call it a brow reset. And why are we discussing this? We are discussing this because Mother Gravity, being ever so kind, is pulling us down all the time. And as oculofacial plastic surgeons, we do see a number of cases of dermatochalasis. Blepharoplasty is probably our initiation into aesthetic surgery. But the most important thing is that most cases of dermatochalasis and subsequent blepharoplasty actually have superadded brow ptosis. In fact, if you try to lift the brow in majority of the patients and do a brow reset, you will find that the extra skin actually disappears. You don't even need a blepharoplasty. So in some sense, we are removing skin which is not excess, but is coming in because of the descent of the facial tissues. And that's why understanding brow aesthetics becomes very important. We already know all this anatomy. There's no point in going through it again. But essentially, the upper eyelid hooding we see, starting with especially the pretarsal show of skin becoming lesser, is because of the way our aging processes are going on. There are multiple ways of doing this, and I prefer the temporal brow lift or the brow reset surgery. And how do we do it? We do it, why do we prefer it? Because it's minimally invasive, but most importantly, unlike any other procedure, it gives a natural lift. Thereby, it repositions the brow from where it came in. Thereby, it reduces the lateral hooding of the upper eyelid. And on a 45-degree angle profile view, you actually see a good pretarsal show. I'll be happy to show that at the end of my presentation. So why a temporal lift? It is natural. It preserves a natural expression, does not allow people to look surprised, and there's a faster recovery. All the incision lines are hidden, and it has a lower risk profile. So here's how we do the preoperative marking. And the moment we start to lift the brow, we see that it's the lateral part of the brow which really gets lifted. And this is the way to actually mark it prior to surgery. And then the marking is done just behind in this particular case, is just ahead of the hairline because it's a male patient and there's a significant temporal loss of hair which has occurred. But otherwise, this can be behind the hairline. And once that is done, we actually go downwards and release everything right until the brow as well as up till the conjoint tendon. But we also go posteriorly. And now we go posteriorly almost till the vertex. Why do you need to go to the vertex? Because in a brow reset procedure, the entire scalp is coming forward, as I'll explain in the subsequent procedures. We all understand that facial aging means that descent is about 80%. There have been authors who talk about deflation, but deflation, in my opinion, is not even 20% of the aging process in Indians. And since everything is moving downwards and medially, and the facial skeleton, according to Lambros's theory, is also turning downwards, you have the entire scalp moving forwards. And that's what is causing the heaviness in the brows. And that's why you need a brow reset surgery. So how do you do this? You basically go from the incision, go down, release right under the brow, go up till the conjoint tendon, and sort of figure out a way to join the central zone and the temporal zone. So this is the way that it's done. Used to do it with an endoscope a long time ago, but now with one of these great instruments which allows endoscopic light to go in, you can visualize it really well and take into account anatomical landmarks and take it forward. You first do a complete local anesthetic in the area and then release it. In fact, we release in this particular area right up till the corrugator superciliaris of the opposite side, and then almost join it onto the other side of the forehead in order to get a completely free area. You can actually pass your your finger through and see how it's being released all the way around, and then you close it up in layers. Once this is done, we see great results. Who is it for? Literally everyone who has a heaviness or a dermatochalasis in the upper eyelid. You should be looking for the fact whether there's a little bit of a brow ptosis or not. Any asymmetry or a flattening of the brow arch are the patients in whom you'll do it. Looking at my patient here, we can see that there's a flatter eyebrow arch. The right brow is lower than the left. She's a 35-year-old lady. Once we correct it, you can see that both eyebrows now appear much more symmetrical. Both eyes appear much more symmetrical. Even though we've done nothing for the eye, it's just the brow reset which has been done. You can see laterally how the pretarsal show improves, and on the other side as well. Similarly, for this particular patient, very thick brows, very heavy brows, excess skin, and the left brow is lower than the right. Again, the same thing. The moment you do that, you see the arch of the brow is now restored, and you can see how the pretarsal show has improved, especially on a lateral view and on a lateral view on this side. So all in all, this is why we do a temporal brow reset. Thank you once again for a very kind and a patient hearing.
I think it was an excellent presentation, Devraj. Even I do a lot of temporal brow lifts. A few questions that I wanted to ask you. What is your post-op regimen in these patients? Do they have this kind of headache and heaviness, and what do you prescribe post-op?
We use tranexamic acid during the surgery. which also has led to a significant amount of reduced swelling post the surgery. And after the surgery, it is just the typical antibiotics as well as a combiflam or a painkiller SOS that seems to do the job. Another thing that we've started doing, Preeti, now is we tie a headband for at least 4 to 8 hours before the patient is discharged in the evening. These surgeries are done under general anesthesia. And once we do that, the swelling reduces significantly and the patient is much more comfortable when they are released by the evening.
I like to add a pregabalin to my post-op regimen sometimes because the nerves get disturbed in that area and patients are very happy with that. And some of them get migraine, people who are prone to migraine. So you can give some prophylaxis for migraine also in these patients. Also, how do you fix the area? How do you fix your bro lift?
It depends on whether there is enough, the deep temporal fascia or the temporalis muscle is there or it's not there. So actually, how far do you take it? You take the brow up and you let it sort of settle down. And then you fix it in place wherever it is. Now, different people are different. In some patients, there's a deep temporal fascia here where we want to fix it, or there's some soft tissue where you can anchor it. In some other patients, there is nothing but bone out here. And when there is only bone out here, then you make use a 0.5 mm screw, guard on a drill and do a bone tunnel out here and fix it at the bone tunnel. So 2 bone tunnels using 2 figure-of-8 stitches, one vertically and one horizontally, fixes this really well, and then the results last 5 years plus.
Yeah, that's what I also prefer to do. Thank you.
I've tried all of this, Preeti. I've tried endotines, I've tried everything. But for Indian brows, using an endotine, sometimes it can be felt from outside, which actually makes things not so aesthetic for them. And then it costs a lot, and then the results also don't last very long.
Thank you.
Thank you, sir. So now I would like to introduce our next speaker, our dynamic surgeon, Dr. Shubhra Goyal, who's the director and founder of Clinica 5 Hyderabad. Over to you.
Thank you, team. I'll be just focusing on what you see is not what you see. I think aesthetics is all about that. And I think we had interesting cases since morning. So this 5 minutes talk is not about me talking, but you teaching me what to do and what not to do. I don't know what to do with my patients. So I'm from Hyderabad. I've been in practice for 20 years and so, and it's been a wonderful journey. And these are my past associations and a big bow to all my teachers because of whom I'm here. So this is the case. I want the audience to tell me, what is it? We are talking aesthetics, so don't look at eyelids and squints and all that. So lower lid fullness, patient presented to me for treatment. What would be your first impression when you see this patient walking in or examining? Audience? No. Look at the fullness and the lower lids. Eye bags, right? So all of us would think this is, what is it? How do you proceed here? It's not moving ahead. Okay. It's not, okay. So this is what you would assume, right? That this is lower lid bags. We'll go ahead with transconjunctival blepharoplasty. We'll remove the fat, isn't it? So the topic is what you see is what you don't see, or what you don't see is what you see. So now think of it differently. What do you think it could be? Okay. So I need the, it's not moving. Okay. So again, look at it. The patient is in up gaze. I think we should drown the lights a bit. So there is a fullness here, and focus on this pigmentation area here. There's a periocular pigmentation. What it could be? So patient had lower lid fillers done somewhere at least 3 to 4 times. So this is a filler placed wrongly in a wrong plane with a lot of pigmentation and Tyndall effect, which has happened over 1 year. And this is the, why do you proceed? Sorry, it's not my laptop, so it's getting stuck. So this is after the high lace. We have high laced it. Of course, she has under eye hollows and pigmentation, which has to be dealt little later. So not all the bags which you see is bags. Not all of it is fat pads, okay? Another very beautiful case came to me. You can see some sausage deformities and fullness here. Look at a face in totality, not just focus under eyes. What do you think this is? Lower lid bags? Okay, good thought. Upper lid, upper gaze and lower gaze. I'm showing you the lower gaze on purpose. So usually when you have lower lid fat pad, it's going to retract, isn't it? So do you think this is something else happening here? No. No. Yeah, lymphedema is part of it, I agree. So this is autologous fat transfer done in the lower lids by obviously not an oculoplastic surgeon. And if you look at her cheeks also, there is quite a bit of fullness and that bogginess which comes with the fat transfer. So these were pockets of fat which were deposited, and then we had to open it and remove it. And this is the patient after the procedure. Some amount of lymphedema still stays because this is chronic lymphedema, which takes time to settle down. Okay. This is my case, a simple blepharochalasis. I think I presented somewhere else also in the past. And as a routine case, blepharochalasis, it has settled. Patient is in the, in the quiet phase. You go ahead and do blepharoplasty, right? This is what I get after 2 weeks of surgery. So this is how the pigmentation and the skin has behaved. And this is how the patient is still with me after 6 to 8 months, or rather 9 months of treatment. So what is happening here? Is there something I missed? I overdid, underdid? What was happening? Because it doesn't look anything fishy when we look at the upper lid skin. Any thoughts? Anyone? No, of course, this is blepharochalasis. It's not dermatochalasis. Patient is in a quiet stage. There was no recurrence, no reactivation, and that's why we went ahead with blepharoplasty. Okay, but this is after 2 weeks. You see the hyperemia in the skin, the pigmentation, and there's no cautery used. Because in blepharochalasis patients, I don't use the cautery on purpose because patients can have PIH and necrosis. No, so we send the skin for biopsy. Just one last case. And it turned out to be the unhealthy collagen synthesis for the patient. She has an underlying syndrome where her collagen is not doing well with type 2, type 4, and so on. So we had to work on a systemic healing for the patient along with other supplements. Very interesting case. We have time, 2 more minutes. Yeah. Resting phase, patient is like this. When she's smiling, she's like this. And when she's smiling even more, this is how it is. This is 10 years after the initial treatment done. Patient is a celebrity. This is Bhaktama and all they do in Telangana. So she's one of those dancers. So her features and her smile is very important to her. What do you think is happening here? I had an ultrasound picture, but I lost it somewhere. So I would have showed that to make it more obvious. Yeah, it's again a filler, which was done 10 years back. Okay. One of the HA fillers. Again, I don't know what plane has been done. We went ahead and did a transconjunctival blepharoplasty to see if we can remove it. We didn't find anything. We did Hyalase. We couldn't dissolve it. I did pre-tarsal orbicularis oculi Botox to kind of relax the orbicularis in a thought that if I relax the orbicularis, probably the sausage deformity will not be so prominent when she smiles, but she stays the way she is. So some of these cases we really can't do, and they're really the botched up cases. Okay, so last case to end the day or end the session. I'm the last speaker, right? Yeah. So this is one of the presentations, physician by profession presented, have spent a bomb with one of our competitors, and she says, I'm not happy. This is how she is when she smiles. The key here is lips. If you look at your lips, you know what's happening to her face. So a botched up case of fillers and Botox charged like a bomb, which you and I can't even think of charging to our patients. Patient landed up in facial paralysis, which is iatrogenic facial paralysis because of long sites of injections and fillers being given. You really can't do anything in these patients, but wait and watch for the botulinum effect to settle down. And I'm not a big fan of dissolving fillers in such patients because no matter how much you dissolve, now we have cases presenting over 5 to 6 years where the HA is kind of loculated and sitting and it keeps coming back. And the more you dissolve, the more collagen depletion you're doing. So for lips, I said, because from the lips you can make out the patient had undergone a filler, right? So because she is a physician, she didn't open up initially what happened to her. And then slowly history came out. Last case, quick one, ptosis done 5 times somewhere, persistent edema. This is how she keeps coming up and down. I didn't touch the patient. CT scan, MRI reports are normal. There is no idiopathic orbital inflammation happening. I'm still wondering what's happening to the patient. Any thoughts if anybody has seen such cases? No, myasthenia ruled out, everything ruled out. There's no IOID, CT MRI with contrast is normal. She just keeps getting these recurrent attacks. So I've given course of steroids, I've given course of NSAIDs, and we're just waiting and watching what to do. I did open the lid once to check if we find anything abnormal. She had old sutures, which were ethibond, with which the levator was tagged as a resection. So ethibond was removed. I don't know who did it, but this is a persistent inflammation, and this is how the patient keeps presenting. Anyway, so I open these cases to the audience to think over and give me the feedback, because some cases we really don't know what to do and how to deal with them. And not all the lower lid bags which you see in your practice are lower lid bags. It could be fillers, it could be fat, it could be botched up fillers, it could be long-standing fillers, it could be so many other things happening. So look out for those cases, assess these patients in totality and deal with them. And they are tough to handle. Thank you so much.
Thank you so much, ma'am, for an excellent presentation. Someone has some comments.
Somebody else is talking. So I had a few questions. Have you seen any Hyalase allergy? Because I have seen these kind of patients, like the one you showed, facial palsy. That was very interesting. I mean, we do see patients, we give Hyalase and it keeps coming back, like you said. So what do? You just leave them alone?
So Preeti, Hyalase sensitivity I have not seen on the face, but repeated Hyalase injections are leading to collagen depletion and pitting on the facial thing. So you can, it comes back. The face collagen does come back. You need to supplement them with oral collagens, IV collagens, and so on, and some other treatments. Hypersensitivity and reaction with Hyalase I've not really seen. As I speak to you, I'm dealing with 4 cases done elsewhere, injected with fillers. And I've been dealing with them for over a year. We keep dissolving them and they keep coming back. So the key to such cases is, once a botched up is always a botched up. Botox anyways, you have to wait and watch. Fillers, it's best not to touch as much as you can. As a personal choice, I'm not saying that's the choice for everyone, because there's no end to it. And more case studies and dynamic MRIs are now showing how the HA fillers are actually expanding on the face. And they keep staying there, they stay there. And, we have cases up to 15 years. I think there was one case where the expansion of HA fillers have done. So it's very important who's injecting, where it is being injected, and what was the technique used. So these are just learning lessons for us for what not to do and what has to be done correctly and how much to be done. Because I think the filler market is just kind of going crazy.
Yeah. I think a lot of surgeons have now moved to fat injections, but like you showed.
Fat, another story. Yeah. So the fat, again, the problem with fat is the autologous. You don't know when it's going to expand and shrink. Again, under eye is very tricky, because even if you're dealing with nano fat, what's your plane of injection? And most of the patients are being dealt with plastic surgeons. Not that all plastic surgeons are not doing it well, but somewhere we are rupturing the septa, we're putting it in the wrong plane, and we have an encapsulated sausage, which is just not coming out. It refuses to come out. This lady was lucky where I could open it up and remove it in totality. But it's a long-standing case, because then now I have to deal with a lot of fibrosis. I have to deal with a lot of post-care with her in terms of lymphedema, hyperemia, pigmentation, and so on. And they're never happy patients.
And the last patient, that edema of the eyelid, could it be autoimmune or something like that?
I did all the tests, Preeti. So everything is negative. So I'm not sure. It's a very, very tricky case. I am still dealing with it. So I mean, posted it here too. If anyone has seen this happening, because I don't know, I really don't know what to do with her. So yeah, biopsy is all normal. There's nothing. It's all clean. Everything is done.
So thank you, Dr. Shubhra. This ends the aesthetic session, and now we'll move to the eyelid session. I would like to call Dr. R.P. Mora to please chairperson here. Meanwhile, we can have the photograph of the aesthetic session here. So you can please come forward for the next session.
Can
Thank
you
you.
put the virtual ones behind?
We'll start the next session. So Dr. Amnisha Sarkar. Yeah. So she'll be presenting on child with ptosis, the diagnostic and therapeutic dilemma.
Should I start?
Yeah, please.
Okay. Good afternoon, everyone. Grateful to have this podium. Today, my presentation will be more of an open-ended discussion on variable ptosis which result from long-standing cases of VKC. So for the ease of discussion, I have divided my presentation into few heads. First, we will go ahead with a short discussion on the etiopathogenesis and course of ptosis in VKC, then the management protocol and also the dilemma associated with it. Also, we're going to intervene surgically, few review of literature after this. To begin with, I want to present two cases which I have recently encountered in our oculoplastic clinic. The first case is a 13-year-old male who presented to us with a drooping of left upper eyelid for 18 months. He gave no history of trauma. Also, he denied any history of ocular allergy or habitual rubbing. Systemic history was also quite within normal limit. On examination, we could find a moderate ptosis of the left upper eyelid. The MID-1 measured 1.5 millimeter. There was a well-defined lid crease. LPS action was good. Bell's was good. Fatigability was absent. There was mild circumciliary congestion, also few papilla over the upper tarsal conjunctiva. Corneal sensation was quite within normal limit. So here is the photo of the patient. And I don't know whether it's very prominently visible, but if you can see on the nasal breach and on the superotemporal area, there were a very mildly scaly hyperpigmented lesion. And the father clearly said that this dermatological lesion is waxing and waning in nature. And with the improvement of the lesion, the ptosis also improves. And that has been happening for quite 1.5 to 2 years now. This picture I have collected from his mother's phone, dated back 2 years. And here we can see both the eyelids are quite symmetrical, and also there was no apparent ptosis. So we advised the patient for anti-acetylcholine receptor antibody, anti-mask antibody, which eventually came out to be negative. and kept the patient on low-dose topical steroid tapered over 4 weeks, topical antihistaminic, lubricants, cold compress, and also preferred him for dermatological consultation and called him after 2 months. Unfortunately, the patient never came back, but on inquiry over phone, the father said that they have visited a dermatologist, also followed our prescription, and the ptosis has improved with the improvement of the dermatological lesion again. Coming to our second case, it's an 8-year-old girl who presented to us with itching and redness of both eyes off and on for about 4 years now. On examination, we could notice a severe ptosis of both upper eyelid, MID-1 measured -1 millimeter in both the lids. There was a well-defined lid crease, LPS and Bell's was good. There was severe frontalis overaction, not very prominent in the photo, but frontalis overaction was significant. Fatigability was absent. Surprisingly, the mother and the child, they never complained of the ptosis and they were completely unaware about it. They only complained about the itching. Probably maybe due to the severity of VKC. There was conjunctival congestion, diffuse, and there were numerous papillae over the upper tarsal conjunctiva. Cornea and limbus was within normal limit. So we prescribed the patient on low-dose steroid tapered over 6 weeks, topical antihistaminics, oral antihistaminics, lubricants, and cold compress. This is the patient after 2 months. We can see that the ptosis has significantly improved. Now the MID-1 measures 2 millimeter on both the sides. Frontalis overaction has also reduced, conjunctival congestion reduced, papillae reduced. So now the dilemma, whether to continue with the topical steroids, because topical steroids itself has been found to be associated with ptosis, whether to intervene surgically now, and if we have to intervene, what surgical approach to be followed now. But anyway, we started her with topical tacrolimus ointment for 3 months, lubricants and cold compress, and asked her to come back again after 1 month. With this, I would like to speak a little about the etiopathogenesis of ptosis in a case of VKC. There are several factors which has been studied in literature. First is a long-standing inflammation due to allergy which spreads to the eyelids from the conjunctiva. Then the giant papillae plays a very significant role staging the LPS aponeurosis, constant irritation, and also skin and soft tissue changes. Literature studied have showed that in case of constant use of topical steroid, there happens thin LPS and slack LPS aponeurosis. Also, electron microscopic signs have showed signs of apoptosis, which have eventually led to ptosis. Regarding the course of ptosis in VKC, it can be unilateral, bilateral, worsens in active phase, improves with remission, and becomes permanent after a certain phase. Coming to the management, the guideline says first treat the VKC and treat the VKC well. So we can do it with all the available drugs, topical antihistaminics, topical corticosteroids, dual-acting agent, also oral steroids. Now the dilemma actually starts when to treat the residual ptosis. Most of the studies have showed 3 to 6 months, but there's no definite guideline regarding when exactly to do the surgical correction and what is the best approach. Several surgical approaches have been described. Quick review at the literature. There has been a study by Ashraf Pwani et al. Who have showed that in a case of 60 patients, they have studied 15% patients developed ptosis. Unilateral ptosis was much more common than bilateral. Also, the palpebral form was most commonly associated. Another study by Griffin et al., I shall just be quick. This has showed that the progression of ptosis remain undetected in most of the cases due to the severity of VKCs. The pathogenesis has been attributed to giant papillae and also to mechanical microtrauma due to habitual rubbing, and that has been showed that the ptosis is more common on the dominant side than on the non-dominant side. As intervention, they have mostly done anterior approach LPSR, and that have showed good result. Again, the timing of the surgery and its effect on progression has not been mentioned by the authors. My last review of literature is a case of an 8-year-old girl. The study has been done by neurologist, and it was a case of intermittent ptosis, waxing and waning. The giant papillae corresponds to the degree of ptosis. However, there was no mention regarding the LPS function and the eyelid crease, and they have shown that the ptosis has completely recovered after conservative treatment only. So after all this discussion, what remains in our mind is when exactly should we intervene surgically? Because none of the books and none of the literature has shown the exact timing to intervene. Also, in case of a mild ptosis, few have recommended MMCR and few have not, because the conjunctiva in most of the cases has already been compromised. Another question which comes to our mind, if the ptosis is visually significant, whether to wait for the complete remission or whether to intervene early. Also, I have done few literature review, but I have not found any ptosis which have been associated with any skin lesions. So if anybody has any input regarding this, thank you.
So, thank you. Thank you, Dr.
Thank
Satta.
you.
Any questions? Sir, any comments?
VKC looks like blepharophimosis syndrome and congenital ptosis.
So it didn't seem to be a blepharophimosis. Okay.
Can show your photograph
Okay,
of the second
yeah.
case. Just to discuss. You have to evaluate for the congenital ptosis. I'm saying.
Yeah, thank you so much, Dr. Anisha. So I request all the speakers to please limit to your time given. So do we have Dr. Gautam here? Dr. Ruju? Dr. Ruju is joining online. Is she there? Dr. Isha? Dr. Pooja? Dr. Isha is here. Okay, yeah. So now I invite Dr. Isha. So she'll be talking to us on beyond meibomitis. Could it be something more?
A very good afternoon to everyone present, respected judges and dear audience. So my topic today is beyond meibomitis and blepharitis. What could rare twist to it be? I have no financial disclosures or any conflicts of interest. So conventionally, a meibomian gland dysfunction or blepharitis is a chronic diffuse abnormality of meibomian glands, commonly characterized by terminal duct obstruction and qualitative and quantitative changes in the glandular secretions. But what can be the rare twists and turns to a blepharitis? So we have 4 cases today. In the first plot twist, we have a 13-year-old female who came with a complaint of rash and eyelid swelling along with itching for 3 months. It was treated as MGD from elsewhere for 3 months and patient had no improvement. She also had a complaint of rash over the face, which had the indurated papular-like acne-like lesions. On eversion, we found the thickened tarsal plate. Patient had no pain or tenderness and had more signs than the symptoms. So, in our plan of management, we planned a conjunctival HP biopsy where we found granulomatous inflammation with caseating necrosis. Scraping from the lesion showed negative result, and the patient also had increased DSR, MON2 positive. So a provisional diagnosis of eyelid TB was made. The patient was started on ATT, and post 1 month of ATT, patient had complete resolution of the symptoms. Our second plot twist was a 40-year-old male who came with a complaint of eyelid swelling for 2 months. Patient had no insect bite or any history of trauma and was treated on multiple antibiotics elsewhere for 1.5 months. On examination, patient had diffuse upper eyelid swelling involving the skin and subcutaneous tissue. Tarsal conjunctiva was normal and meibomian gland orifices were not plugged. So here a plan of management was an incisional biopsy where we found nodular aggregates of lymphoid cells with emperiopoiesis. To rule out Rosai-Dorfman disease, we did an IHC where CD68 and S100 were found positive. So Rosai-Dorfman is a rare non-malignant histiocytic disorder. Patient complains with painless cervical lymphadenopathy, and on HP, we find abundant histiocytosis. A provisional diagnosis of Rosai-Dorfman was made. The patient was started on intralesional triamcinolone, and post 1 month of treatment, he had complete resolution of the swelling. Our third plot twist was a 13-year-old female who came with multiple eyelid swellings in both upper and lower eyelids at the age of 5 years. She also had a different plot twist here. She had diminution of vision for 2 to 3 years. She was treated as blepharitis from multiple places and was on steroid and antibiotics since the last 7 years, on which she developed posterior subcapsular cataracts. Our plan of management here was an incisional biopsy where we found deposition of past positive hyaline material in the papillary dermis. Patient also had hoarseness of voice with furrows over the tongue. So a provisional diagnosis of lipoid proteinosis was made. And our final and the fourth plot twist was a 60-year-old female who came with complaint of redness and loss of lashes in the upper eyelid. On examination, patient had congestion over the bulbar and palpebral conjunctiva with loss of lashes and loss of architecture of the both upper and lower eyelid, and a diagnosis of diffuse sebaceous gland carcinoma of the eyelid was made. So here we had 4 different scenarios who came with similar complaints and underwent an similar initial management. All the patient had non-resolving symptoms on initial management. So what do we do in these cases? We do a biopsy and rule out the possibility of any other condition, and we do a thorough systemic examination. So our take-home message from these 4 cases would be, if anything looks like a MGD, blepharitis or blepharitis, but is persistent and non-responsive to conservative management for over 2 months, is unilateral, have signs more than the symptoms, it warrants a further evaluation to rule out neoplastic or infiltrative pathologies. Also, if it looks like recurrent chalazion, but if it's not resolving, it should always be sent for HPE, and always a thorough systemic examination with face, scalp, and local lymphadenopathy could give a clue to the diagnosis. Only if we closely look and examine, we might be solving many war scenarios, even in atypical blepharitis. I would like to thank the local organizing committee who have made this conference possible even in this war scenario, and also our soldiers who are fighting the borders and have made this conference possible in this difficult time. Thank you.
Thank you, Dr. Isha. So any comments from the audience, please? Okay, if no, so we'll be moving on to our next speaker, Dr. Pooja. I think she is joining us online. Is Dr.
Good
Pooja
afternoon,
there
ma'am.
online?
Good afternoon, ma'am.
Yeah, so Dr. Pooja will be talking to us on recurrent left upper eyelid neurofibromatosis in a child. What should we do next?
Thank you, ma'am. I shall be presenting.
Just a second, we'll just share your screen and you can then start.
Sure, ma'am.
Yes, Dr. Pooja.
Good afternoon, all. I shall be presenting a recurrent left upper eyelid neurofibromatosis in a child. What should we do next? So, my case is a 6-year-old male presented last year with gradual painless progressive swelling in the left upper eyelid since 4 to 5 months of age with no other significant contributory history. On asking the treatment history, he gave a past history of left frontal craniotomy with debulking surgery done 1.5 years back by a neurosurgeon. Patient remained asymptomatic till 1 year when he started noticing a gradual increase in his symptoms. On inspection, there was fullness in the left upper eyelid. There was mechanical ptosis, which was obscuring the visual axis with mild proptosis. However, the overlying skin was normal, except for the fact that there was pigmentation and scar mark, which was present on the upper eyelid, which was suggestive of previous surgery. And on lid eversion, there was thickened floppy lid with mild congested conjunctiva and kinking of tarsus, which can be seen. However, there was no redness, ulceration, or bleeding from the mass was noted. On palpation, there was mass in the upper eyelid, which was soft in consistency, giving the bag of worms feel. It was non-tender, compressible, freely mobile, not adhered to the overlying skin or the underlying structures. It was ill-defined. It has ill-defined margins, and the posterior extent could not be reached. Patient had no lymphadenopathy. So we make the clinical diagnosis of neurofibromatosis, and on clinical examination, cafe au lait macules were seen on his abdomen and both axillae. On ophthalmic examination, the best corrected visual acuity in the right eye was 6.6 and in the left eye was 6.12. Rest of the ocular examination was within normal limit. On contrast enhanced MRI, which the patient already had, we could see on the mid-axial scan, we could see a soft tissue, irregular soft tissue mass in the preseptal area, which was going posteriorly till the optic chiasm. So the diagnosis was made of left upper lid plexiform neurofibromatosis, and the debulking surgery of left upper eyelid was done. Skin marking was done, and skin and orbicularis were dissected, and debulking of tissue was done, and gross specimen was sent for histopathological examination. And the surgical pathology report confirmed left upper eyelid plexiform neurofibromatosis. On POD1, the patient was fine, but after 4 months in recent follow-up, the patient again had progressive upper eyelid swelling. On CE-MRI, there was no change in the size of intraorbital and intracranial part after 4 months. So what should we do next, surgery or the novel targeted therapy? So I have no financial interest. The drug name is the selumetinib, the Koselgo, which is highly potent and selective MEK1/2 inhibitor. It is indicated in child more than 2 years for the treatment of inoperable and symptomatic neurofibromatosis type 1. So there have been phase 1 trial in 2016 and sprint phase 2 trial in 2020. Both are suggestive of the dosage 25 milligram per meter square daily in continuous dosing. The overall response rate in the phase 1 trial was 71%, in phase 2 trial was 68%, with tumor shrinkage of approximately 30% in both the trials. And the quality of life, there was significant improvement in the quality of life in both the trials, with mild or reversible adverse side effects like mild rash and GI toxicity and increase in creatine kinase phosphatase. So this drug has got the FDA approval in June 2020 for children aged more than 2 years and older with neurofibromatosis type 1 with inoperable symptomatic plexiform neurofibromatosis. Thank you. I have no financial interest.
Dr. Pooja, any comments, please? So, is that drug is available is the question, Dr. Pooja? Is it available in India and the cost?
Okay. What's the cost?
Yes, ma'am. The cost is, ma'am, for 25 mg, it is around 11 lakhs for 60 capsules, ma'am. It's quite costly.
Yeah. So everyone is stunned with the cost, so that
Did you use it in the patient? Is my question.
Ma'am, we are planning to do it for our patient. We have brought a letter to the government and our NGO for supporting our child.
We would like to see the picture of the.
I would rather like to know the NGO which will support. We have so many patients and we would like to have supports for them. Only one comment that rather than doing just the debulking in the thickness part, if you would have reduced the horizontal length of the lid.
Yes, sir, we have done that, sir. The horizontal laxity was also reduced, sir, by giving we have done that, sir.
Okay, I couldn't see that in the picture, so I missed it probably.
Sorry, sir, I didn't put that in the slide. Sorry.
Yeah, thank you. So I hope Dr. Pooja would be sharing the post-op picture in their oculoplasty group. So, sorry.
We have used this drug in orbital neurofibromatosis, and it has shown a good promising result.
Was
And
that
the
patient
child-
affordable?
Others company.
Okay, ma'am.
It's very expensive.
Yeah. Thank you so much, Dr. Pooja. So now I'll call upon our next speaker, Dr. Anupam. Dr. Anupam. Dr. Anupam. So the topic is on a challenging case. So she'll be talking to us on a challenging case of post-traumatic ptosis managed successfully with facial atrophy.
Good afternoon, everyone. At the outset, I will like to thank the organizers and Dr. Vishal and his team for giving me this opportunity. I will be talking about a challenging case of a post-traumatic ptosis managed successfully with facial atrophy. A 46-year-old male presented with drooping of eyelid for last 3 years. He has history of trauma with a metallic tin 3 years back, and after that, lid assessment was repaired outside, and nothing else was done. And all history was negative regarding diplopia, any other ocular surgery or ocular deviation, any diurnal variation, contact lens use, and any systemic illness, and there was no family history. Past illness was insignificant, birth history was normal. He was a laborer of profession, and he was a non-smoker, non-alcoholic, having mixed diet and normal sleep pattern. He was very much concerned about his complete ptosis because he has lost his binocularity and he was not able to earn his livelihood. Head posture, on general examination, head posture was abnormal with chin lift, and the build was moderate. Patient was afebrile. Other vital parameters were within normal limit. On ophthalmic examination, right eye visual acuity was 624, improving to 618 with pinhole. Left eye was 66 parts. Other pupil and IOP was normal. On palpation, inferior orbital limb was discontinuous with no crepitation and tenderness, and left eye was normal. And there was a complete ptosis with significant adherent scar at the superior, just behind, below the superior orbital rim. And there was 2 millimeters of dystopia. The right eye was 2 millimeters displaced inferiorly most probably because of the malunited fracture of inferior orbit. And Sharmas were 10 and 12, and tear frame wake-up time was 5 seconds in right eye and 8 seconds in left eye. On anterior segment examination, there was mild staining on grade 1 in inferior quadrant, and the best corrected visual acuity after cycloplegic refraction in right eye was 6/9 parts and left eye was 6/6. Posterior segment was normal. When we came to ptosis workup, MRD1 was -4 in right eye and MRD2 was 6, MRD3 was -2, and he had a significant most probably acquired because of the malunited fracture of orbit, fracture inferior wall of orbit. And eye-spec test was negative, MGB was negative. LBS action was by Burki's method was 2 millimeter only, while the other side it was 12. So this is a picture of a patient having right complete ptosis with absent lid crease and with all adherent scar. And 9 days picture is suggestive of acquired monoocular elevation deficiency in right eye, but patient was not having any kind of diplopia. Patient was orthophoric in primary position. So the final working diagnosis was right upper lid post-traumatic apneurotic complete ptosis with vertical dystopia with right acquired monoocular elevation deficiency without any complaints of diplopia. The viral markers, left cavity was within normal limit, and previous CT was suggestive of a fracture lower of inferior wall of the orbit, and that the picture was not clear, and we were planning to explore the LPS, so we advised contrast enhanced MRI brain and orbit, and LPS was found to be normal on coronal section, but on oblique sagittal section, we could make out the insertion of LPS aponeurosis to the superior border of tarsus in left eye, but we could not trace the LPS beyond the superior orbital limb and beyond the vitrinal in right eye. So what challenges were there in this case? The presence of dystopia with MID, with risk of postoperative diplopia. Then significantly adherent scar, mismanaged lid recession repair over the superior orbital limb, making the frontalis slit surgery very challenging for us, and it was very challenging. And the postoperative, there was increased risk of exposure keratitis due to poor fair bells and MID and malunited fracture floor of the orbit. But with the help of my burn and plastic team, we planned the surgery. And as patient was insistent and adamant to get surgery done because he was not able to perform his laboral duty because of loss of the binocularity. So with all risk explained, the patient underwent right eye Crawford technique of frontalis suspension with Pasaletta autologous sling with my burn and plastic team. And this is the postoperative outcome. Visual acuity was on day 1 was 618, improving to 612. And staining a bit increased to inferior 3 quadrants. And T-BOT was the same. And patient was managed on the frequent topical drops. And this is the first post-op follow-up. And this is 1 month follow-up. And patient is happy. Although the doses is undercorrected, there is no exposure. Patient has regained his bioavailability. And after 1 year of follow-up, patient is able to perform his laboratory and is able to earn the livelihood. Thank you.
Thank you. Any comments from the audience? Thank you.
Thank you, ma'am.
So now we have Dr. Farnaz. I think she's joining online. Is she there?
Yes, ma'am.
Yeah. So Dr. Farnaz will be talking to us on a tearful twist in upper eyelid reconstruction. Over to you, Farnaz.
Hi, hello, and a very good afternoon. I'm Dr. Farnaz Yazir, and I'll be speaking on a tearful twist in upper lid reconstruction. So we had a 60-year-old female referred to our ocular oncology clinic with a history of right upper lid mass for the last 1 year, gradually increasing in size and treated as chalazion over the last 1 week with no prior surgeries done. General examination and ophthalmic evaluation revealed regional lymph nodes to be negative, visual acuity in the right eye 6/6 with good pseudophakia, rest anterior segment being within normal limits and the disc being healthy. Local examination revealed an approximately 15 × 17 × 4 millimeters measuring irregular and hard mass located at the junction of the medial 2/3 and lateral 1/3 of the right upper lid, extending to the upper palpebral conjunctiva, tarsal conjunctiva, involving the entire superior fornix.
Just a minute. Farnaz, can you
Yes.
please change your slideshow? No? Presenter se hata do.
1 second.
Just reshare the screen again.
Ma'am, just ensure that you are not sharing in presenter's view. The presenter's view for you. You just do a normal share. The presenter view for you will always come. Yes, awesome.
Please carry on.
So involving the superior fornix, medial and lateral canthus as well. So a clinical diagnosis of right sebaceous gland carcinoma with pagetoid component was made, and we went ahead with map biopsy in order to delimit the extent of pagetoid invasion. So only the caruncular conjunctiva was positive, whereas the area which was away from the main tumor was all negative for map biopsy, and thereby we went ahead with excision biopsy with frozen section for margin control, and also the adjacent tissues were also sent for confirmation by the histopathology, and everything else was negative. So thereby we went ahead with Cutler-Beard stage 1 eyelid reconstruction as well. So this was the gross specimen, and thereby the histopathology microscopic sections, as you can see, showed nuclear atypia and mitosis as well. So confirming sebaceous gland carcinoma. In stage 1 post-op 2 weeks, there was lid edema and ecchymosis. So even after 6 weeks, there was persistent boggy lid edema in comparison with a patient who underwent the same procedure, who had normal healing. So as you can see on your left-sided image, there was persistent boggy lid edema. So with a suspicion, there was also a history of poor hygiene, and whenever we could clean also, there was poor hygiene. So with a suspicion of infection, we went ahead with Cutler-Beard stage 2. So in that, what we could actually see, so after the skin marking and layer by layer dissection, when we were almost closer to the cornea, a bluish hue was very much visible. So now we
बाद में होंगे, मेरा टाइम हो गया था. And thereby there was a jet of clear fluid that was actually
जो जो नया
Please continue. Doctor.
So this was the twist in this case. There was tear accumulation that had happened over the last 2 months because of the extensive dissection that was done in Cutler beard stage 1. And Cutler beard stage 2 was further done in the regular steps. Lower lid debulking was done, lid margin and suturing, and further the upper lid was reconstructed with the skin and glue, the conjunctiva was approximated with glue. So the bridging flap or the Cutler beard technique was first described in 1955. It was used for large upper eyelid defects, especially in eyelid sebaceous carcinoma. The possible complications are necrosis of bridging flap, development of lower eyelid ectropia on all these. But tear stasis or the buildup of tears in the eye, it could also be a complication after Cutler beard stage 1. Especially if the flap from the lower eyelid doesn't properly drain tears, improper flap placement, but can also be in cases where we do extensive dissection in Cutler beard stage 1, when there is involvement of the medial canthus or any area which is close to the punctum. So in this case, this was the twist that happened. Thanks a lot.
Thank you, Farnas, for an excellent presentation. Any comments from the audience, please?
What was your follow-up period? What was your follow-up period of this patient?
Actually, sir, the follow-up period was limited only to right away the post-op time. After that, that's the reason there is no post-operative picture of 6 weeks or later as well, because the patient had expired.
Okay. Actually, there is a
Of
chance
cardiac
of
arrest.
okay. Otherwise, the chance of recurrence is common with pegytoid, sebaceous
Yes,
carcinoma, agitation, multicentric origin as well.
Yes, sir.
Hi, Farnaz Fairuzia. Excellent presentation as always. Yeah, I just wanted to highlight something here, especially in sebaceous gland carcinoma, pegytoid, we have burnt hands in these cases. Whenever there is a pegytoid, what I have learned is that when we do a lid sharing procedure, there is a high chance of recurrence in the other lid. Because pegytoid, although we get a negative frozen section, but still there can be pegytoid cells in and around the conjunctiva. And the eyelid which is not involved, there is a high risk of spread to the other eyelid. So it is well thought and said that if it's a pegytoid sebaceous gland carcinoma, as much as possible, avoid lid sharing procedures.
Okay.
Thank you, ma'am. Thank you, Farnas, for joining us. And now I'd like to call upon our next speaker, Dr. Raman Mittal. Sir will be talking on traumatic retraction. Over to you, sir.
Hi, ladies and gentlemen. Very good afternoon. And I thank the local organizing committee, Vishal and Mrs. Vance. Thank you very much for having me here, away from all the bombshells and the missiles which are being hit in my city recently. Though I have, I'm very close to my heart. Every time I feel bad for my colleagues, my friends who are stuck there. But I thank God for having me decide that I come here to attend this conference and I'm a bit more safer. So this is a case which I'm going to share as a case of traumatic lid retraction. This is a case where I did so many surgeries, so many interventions, but still I'm not able to get the desired results. So this is a case which I'm presenting in front of you all, and I'm expecting you all to give me an input. What else can be done in this case? A lady of 31-year-old referred to me by a plastic surgeon with the discharge in the left eye for the last 3 years and constant redness of the eye, multiple attacks of acute decrocystitis with abscess formation in the last few years. She had a history of roadside accident with orbital fractures in 2019, for which an orbital plating was done by the plastic surgeon, which was then removed by him on 2021 September. Thereafter, the patient was referred to me in April 2022 with the visual acuity. Right eye was 6/6, but the left eye had no PL. The lower lid was retracted with cicatricial tethering with underlying bones or the fracture sites. The lag of thalmos was approximately 5 millimeters with lower half of the globe exposed. Inferior scleral show was quite prominent to around 6 to 7 millimeters, leading to congestion. The pupil was dilated and fixed, of course, because of PL negative eye with left optic atrophy, was total pale disc. So the left loaded retraction was my main working diagnosis. And I also did a left syringing, which showed me that she had blocked NLD from the upper punctum. Of course, the lower canaliculus had a fistula, which was there at around 3 millimeters. This was my working diagnosis: left nasolacrimal duct obstruction, left lower lid cicatricial retraction with traumatic optic neuropathy. What could be the plan of action? I tried to diagnose all these. The plan was to do a lower lid cicatrix release with skin graft, and at the same sitting DCR plus intubation, because I'll be opening that area. So it'll be easier for me to do a DCR, because without doing a DCR, as she had acute attacks earlier, I didn't want to risk my graft for a chance of infection. These are the post-operative pics. Surgery was done on June 23. The graft, as you see, was contracting. I was not expecting her graft to contract so fast, so I do not have those pictures, earlier ones. These are a few of the pictures of hers. So these were the findings from my file, that the graft was intact. The frost suture was in place for about 1 week. DCR was fine. Syringing was patent from the upper punctum, so suture removal was done. The frost suture broke on its own in about 2 weeks, which suggested me that there was a lot of traction in the lower lid, pulling the sutures. The syringing remained patent. Post-auricular suture, the donor area sutures were removed. In 5 weeks, the skin graft was contracting again. DCR was fine. Post-auricular donor side was also doing fine. So this is the picture of 5 weeks later. You see that the skin graft is contracting again. The inferior scleral show has again increased to 7 millimeters. Congestion is still there. Lag of thalmos has come back to 3 millimeters. What should we do at this stage? Any inputs? What would you have thought? Yes, ma'am. I did. I told that it broke off. Okay, the lid tarsorrhaphy. Possibly, but I guess when I pull it up, it gives more of a traction rather than if I close the lids, it'll be like the upper lid will be closing anyways, so it won't pull the lower lid up. So a tarsorrhaphy won't help to pull the lower lid up, which was my primary concern and which I wanted. Yeah. Seeing is not a problem. Yeah. So I agree. That could have. Great. So we could have done a 5FU injection. So that is what I did then. So injection 5FU mixed with Canacort. At this stage, I injected, and I also suggested the patient to massage that area of skin graft. But even after so many months, the inferior scleral show still remained to be 5 millimeters. Lag of thalmos was also there, 3 to 4 millimeters. Not much of respite. Any further idea? Yeah, Farooz.
Yeah, Dr. Raman, nice, very interesting case. Would you consider dermis fat graft, where you'll get a dermis, also a volume there in trauma? Yeah.
So you mean a sort of a spacer to increase the full thickness?
Yeah, so it
Great.
is a fat. So she has an excavation over there. So you take a small dermis fat graft, not like the orbital dermis fat graft, a thin one, measuring, of course.
Maybe a
So
dermis and dermis graft, thick dermis graft would do. Dermis skin
fat
graft.
will also help
Fat would
because
also
she has
help.
got excavation over there. She'll get a little bit of fullness also.
Okay, yeah, actually.
Yeah.
No, I agree with her, because basically we have to address what is now the concept of the middle lamella, which is fat and the septum itself. We keep talking of skin and orbicularis, skin tarsus, and then the conjunctiva on the posterior side. The septum and the fat although structurally does not, is just there and can be, happily go in and excise it in blepharoplasty. Functionally, it adds a lot of structure to the lower lid, and that middle lamella can be replaced with a thin dermis fat graft strip.
So agreed. So rather than addressing only the anterior lamella, I need to address the middle lamella and
Yeah.
possibly the posterior lamella as well.
Posterior lamella might be good in this case. If you
Was
see the
not good, but
tarsus.
it was tethering in the beginning very much.
No, so if you release the tethering, the posterior lamella 4 millimeters of tarsus. Even if it's 3 millimeter, it's
No,
not
the
a big deal.
fornix was also shortened.
Ah, right, yeah. Okay.
So
Can I add a point in this?
yeah. Yeah, please tell me.
Yeah, hi Raman. Can I add something to this?
Yeah, Preeti, people are looking in for you. Let me tell them you are a virtual, you are a Devi coming from somewhere in Chennai. Yeah, please speak up.
Yeah, this was a nice case. You know what I
I'm
feel is
yet
that many
not
a
done with the
times in
case.
these
Kindly
cases.
continue with the slides. Yeah, Preeti.
So many a times the inferior orbital rim is not okay in these trauma patients, and that also contributes to the lid retraction. So if the rim is lower, you need to augment the rim with a peak implant or some implant. Only when the rim is in the right place, you will get the eyelid in the right place, number one. And number two is most of the time, all the three lamella are involved in this. So you need a mid-face lift. You need some kind of volume augmentation, like you all said, dermis fat graft is a good option, and some stiffness. So, either dermis or hard palate graft. All the three are needed, and a lot of antimetabolites in the post-op period, like 5-FU, and I don't use Kenacort much. But instead of a skin graft, I would prefer to do more of a mid-face lift and try with that more compared to a graft in the anterior lamella.
Retrospectively, yes, I think that I should have done more than doing just a skin graft. So now at this stage, as we all agree that we should have done with all three lamella or at least two lamella, rather than thinking of dermis, fat graft or orbital rim, I thought of doing a lid sharing procedure where I would be imparting a full all three layers to this lower lid. I explained her that she'll lose the lashes of the lower lid and there'll be chances of watering because of the contour changes. But she had a lot of problem with her congestion and looks. So she agreed to it. And I did this lid sharing procedure for her in which I thought I'll be giving so many more millimeters to the lower lid because the lower lid was retracted. And what we were struggling was to give that extra millimeters to cover the lower part of the globe. So this lower lid sharing procedure was done. I will not go through the video for the sake of time. Everybody here knows how to do a lid sharing procedure, and the stage 2 also I'll skip. So after 1 month of CB2, which was done in Feb 24, inferior scleral show, though it reduced, but still we had a residual 3 millimeter inferior scleral show and lag of almost 2 to 3 millimeter. She was better closure, but not adequate enough. But unfortunately, when she came back, this is not the last visit. She came back 2 days back. I could not put in her visit of that because she was having some other condition of the lid. And so I did not put because that would unnecessarily confuse. So her inferior scleral show again increased in May 24. And the whole of the lid sharing procedure had gone for a toss. And we still have some retraction coming back again. What else could be done now? As guys, do we really go in with dermis fat graft or something? Okay. And as she says, orbital rim. What I missed in her, what I think was that exotropia with the hypertropia in her eye. Probably that was one reason that she always showed that inferior scleral show, which we all oculoplastic surgeons missed here, I guess, because we don't look in for the squinting of the eye. If we bring the eye to the normal position, she would have that reduction of the inferior scleral show, of course. Yeah.
I think this is orbital adherence syndrome. And we should not do anything for at least 6 months.
Yeah, it's 1 year now, and she also doesn't want to get anything now. So let's see what we do. Thank you very much for your attention. I'll be open for your inputs even later if you think I really want to help her. So kindly give me the inputs. I'll pursue her for the surgery. And I promise that I'll share this case of her with most prominent surgeons of the country and bring some solution to you. Thank you very much for your patient hearing. JK wants to say something.
I want just one question. So if we is already compromised,
JK, close to your
yeah,
face.
it is compromised already. There's a scar is already there. If we use thermoplastic graft again, one more injury. Thermoplastic graft also. So in such cases, can we use? Is very easy to decide. If we use some pedicle graft and we can add, so it maintain vascularity also, and it can mechanically also it can pull. Is it possible?
That situation. There is an excavated area over here. And, as Akshay was rightly mentioning, the different lamellas and tissues has to be addressed. So it actually gives a nice fullness also to the tissue over there. And a dermis fat graft takes up. If the vascularity of the in and around tissue is good, it takes up. So, and it epithelializes, like how we put it in the socket, where it conjunctivilizes. Here, the good skin, surrounding skin will really epithelialize. So you get a surface and also a bit of volume.
So you don't need to give a skin graft, free skin graft over that dermis fat graft?
No, Dr. Raman. You don't have, it will epithelialize. So the dermis fat graft has dermis, which is skin, and the fat, which gives voluminizes a little bit.
What if I take the skin also along with the dermis fat graft? Why only dermis fat? Why not epidermis, dermis, and fat graft?
You can, but ultimately the graft, whenever you see, even if you put a skin graft,
it'll go off.
it de-epithelializes.
Yeah, but it'll have some few cells below which will help to.
And then a new epithelium
Yeah,
forms. So it doesn't matter, even if you put a,
because once we peel it off, it'll maybe a lower levels of the dermis also.
Even if we put a fat graft, skin graft, we have noticed that it de-epithelializes.
It de-epithelializes.
Black color and then it de-epithelializes and then you get a new epithelium. So it is either way. Yeah.
Right. Thank you again for this nice interaction. Thank you.
Thank you, sir. So next I'll be calling upon Dr. Shalu Bagijama. So ma'am will be talking to us on a rare presentation of fungal necrotizing fasciitis, dual infection with Aspergillus niger and Candida albicans in an immunocompromised patient.
Good afternoon, everyone. I'd like to thank Dr. Vishala and his team for giving me this opportunity. So I'll be presenting a case of necrotizing fasciitis with a dual fungal infection, which presented with Aspergillus and Candida in an immunocompromised patient. So this 60-year-old female presented in our emergency department with a history of right-sided facial swelling for past 18 to 20 days. They noticed blackening of skin for past 15 days. And she had episodes of fever and dyspnea. She had no history of any dental procedure, any trauma or periocular surgery, but she was a known case of uncontrolled type 2 diabetes mellitus with chronic kidney and heart disease and morbid obesity. She was presented to the nearby hospital where the CT-PNS was done, and we showed the pansinusitis along with the diffuse facial swelling right-sided, and she was managed as a case of orbital cellulitis. But as she had showed no improvement, so she presented to our hospital, and on presentation, we can see there was a gangrenous skin of both the upper and the lower lid, and there was a copious pus discharge beneath this gangrenous skin. There was a sharp, temperature was raised, and it was tender, and she had the facial swelling temporally as well as extending up to the inferior cheek region. And examination, ocular examination, with the Demar's retractor showed rest of the examination with a normal limit. So MRI was ordered immediately, and pre-contrast, we can see the diffuse subcutaneous swelling, and post-contrast, the hypointense area suggests the necrosis, which was seconded by the diffusion weighted image, which shows the restriction in the subcutaneous plane. And the rest of the swelling also extended into the extracorneal space. However, the intracorneal space and the rest of the muscles were intact. And there was a sinus involvement, which was also seen in the CT scan. The lab investigation shows the deranged liver function test, the creatinine was raised, she was anemic, the CRP was strongly positive, and the urine routine showed the bacteria cocci, and the anti-pro-BNP suggested that she is a chronic heart patient. So she was started on broad spectrum antibiotic along with the ambizone and the other supportive therapy. And we planned the patient to take for the debridement along with the biopsy, along with pan-sinus surgery under general anesthesia with high-risk consent due to risk her comorbidities. So this is a post-debridement patient. The patient was continuously, we were debriding her at the bedside also post-surgery, but however, the copious, this yellowish white necrotic material was coming up every day, and we can see the discharge also. And meanwhile, this microbiology report suggested there was a combined aspergillus and the Candida albicans, which proved that the yellowish white necrotic material was due to the Candida. And histopathology, however, the sinus sample showed only the inflammation, but the bacteria, the skin, periocular skin suggested the bacterial and fungal co-infection. So the treatment was revised from amphotericin to isavuconazole, as this can cover both the organisms and it does not require much of the hepatic and kidney monitoring. So, but even after such treatment, her condition was deteriorating, and meanwhile, we also counseled her for hyperbaric oxygen therapy, which the attendants refused. So we took her for the second debridement because as it was a fungal infection, we thought we should do more extensive debridement of the necrotic material. But this time we planned for local as she was not fit for general anesthesia. So this is the intraoperative picture. The whole flap was raised here from the previous debridement area, and then extensive debridement was carried out. So slowly she started signs of improvement. The discharge will reduce and the granulation tissue started setting up. She was improving hemodynamically. She was off oxygen and as she shown sign of improvement, we planned to do after about 3 weeks for split thickness graft, but unfortunately, we lost this patient to her comorbidities. So coming to discussion, we know necrotizing fasciitis is a very rare, rapidly progressive, life-threatening tissue of soft tissue infection and requires urgent intervention. Bacterial neuronecrotizing fasciitis is well documented. However, fungal infection can also lead to this condition, particularly in the immunocompromised individuals. So they have been classified into 4 types, type 1 being polymicrobial, and the type 4, which is very rare, is due to fungal infection. So because of the rarity and the aggressiveness of fungal infection, early diagnosis is crucial to its rapid progression, and especially in the immunocompromised patient, which has a predisposing factor for the fungal infection. So diagnosis is usually delayed in these cases because there are no specific signs. So swelling, severe pain, erythema are the non-specific signs, but the lab tests can point out to a diagnosis like leukocytosis, elevated kidney function test. And there are certain tools like laboratory risk indicators for fasciitis, which can help us in diagnosing these conditions earlier. And because of the comorbidities, the diagnostic value of this indicator has decreases. So there are various modifications which are available, and thus we can diagnose this condition early. Imaging plays a key role, especially the diffusion weighted images, which is useful for mapping the necrotic areas. So management is key is the surgical debridement, multiple and extensive debridement, removing all of the necrotic tissue is the key. We may require multiple settings, and it's thus is the key to for reducing the morbidity and the mortality of the patient. There are various adjunctive managements also been described. IV immunoglobulins are usually used in case where the patient has a group A streptococcus or is in septic shock. So immunoglobulins are used in these conditions, and the therapy like negative pressure wound therapy, irrigation with hypochlorous acid, or hyperoxygen therapy. The main aim, the role they play is because of the irrigation, they reduces the organism load, increases the blood flow, and thus helps in rapid healing. So these agents can also be used whatever available to us. In spite of all the treatment, we have the high mortality rate as high as 80%. So early diagnosis and intervention is the key to reduce the mortality. So take home message is maintain the high suspicion, especially if a patient is immunocompromised and is not responding to the broad spectrum antibiotics. Prompt imaging and early debridement is important, and multidisciplinary approach is key to success. Thank you.
You mentioned irrigation with hypochlorous acid. Over the past 5 years, it no longer is the adjunct. It is the first line treatment for any form of necrotizing fasciitis. Hypochlorous acid basically takes out the free radicals, which then makes the organism susceptible to any form of antibiotic or antifungal therapy. This was, I think, discussed at length, I think, a couple of ASOPROS meetings where the person who had actually proposed this, he was one of the keynote speakers. So, and there have been a lot of publications after that. So necrotizing fasciitis, the treatment, gold standard of treatment now is hypochlorous acid, debridement, and continuation of systemic antibiotic or antifungal therapy.
Yeah, but the availability is the key issue. So
If you see papers, they've got they've given techniques of preparing medical grade dilute hypochlorous acid. It's available.
Thank you.
Ionic silver dressings helps a lot. I have seen one such case, which was, really bad going into the orbit, but then it recovers very well with ionic silver dressing into the wound.
Yeah, but I don't have experience with the fungal, but
Yes,
yeah,
yes, this
the
case was like severe comorbidities, but in such cases which are preventable, that kind of dressings also help.
Okay.
In periocular necrotizing fasciitis, the mortality is not that bad. Means like around 10 to
Yeah,
15%.
that I know. The key, for the reason for her mortality was her comorbidities,
Yes,
not
yes,
the
yes.
fasciitis.
Right.
Yeah.
Thank you so much, ma'am. So I think we have Dr. Rajat online. So he'll be talking to us on overcorrected. Wait before you intervene, and it's good to do that. So let us know what it is. Share your slides. Yes. So you can just.
Is it there?
You're audible, sir. Please continue.
Okay. I'm not seeing the. Okay, so and the screen is there. I mean, the slides are there.
Yes, it's visible and you're audible.
Okay. So, Jai Hind, everyone. So, coming to overcorrection in ptosis surgery. So, this happens when the eyelid is raised too high after surgery, and potentially the main risk being exposure keratopathy and with lag. So we can see both in acquired ptosis, which is more common in adults, and in congenital ptosis. The main cause mainly seen in acquired ptosis, but I have seen equally in both congenital and acquired, and mainly related to the type of surgery done and the method. Before we move ahead, there are two structures which are important in TOSIS surgeries. One is the orbital septum, especially related to overcorrection, and this is the Whitnall's ligament. The orbital septum is a structure which we encounter when we are doing anteriorly. We need to cut this and put the fat behind and identify the levator muscle. The second is the Whitnall's ligament, which are fibrous condensation of the where the muscle meets with the aponeurosis. So these two structures are important when we are suturing after surgery on the muscle. So coming to the causes, reportedly seen more with acquired ptosis because inadvertently we try to plicate it more or excise rather than just reattaching. But not uncommon in congenital ptosis as well because the muscle tissue was replaced by fibrotic tissue, and we need to take the do a good number of resection, a good amount of resection in this cases, which can lead to overcorrection. Poor judgment, well, if the amount of the levator function is misjudged, and so overdo it when the function is good or can lead to it. Surgical technique is more common with anterior approach procedures because we could inadvertently take the septum in the surgical bite or tuck the suture higher up with the Whitnall's band. Septum and Whitnall's ligament, as I mentioned earlier, and suturing if the suture bite is taken too high up. I'll share some pictures of few of my patients. Coming to management, I personally feel that I mostly prefer overdoing it because with time we see that there's some amount of droop in the surgeries, and secondly, undercorrecting, you need to do a resurgery again. But overcorrection, as I mentioned, I have seen that lid droops after some time, and also we can conservatively manage it with lid massage. So this was a patient with left eye. This was, I think, the second or third post-op day. This was after 1 week. This was after 3 weeks. I was tempting to reoperate upon him and loosen the sutures, but continued with lead massage, and this is the post-op. This was just with conservatively managed with lead massage. Another patient, this was, I think, the second day post-operatively. This was after 1 week. And see the good amount of lid closure, which lesser amount of almost no keratopathy, risk of keratopathy. So I deferred surgical intervention. This is after 3 weeks when he came for follow-up. Another patient, right eye. She was a bit unhappy. I suggested to her that probably you need surgery on the left eye as well. Although I know that there's some amount of temporal retraction is there on the right upper lid, which was operated. So I advised lid massage, and so she was happy. This is how massage is advised. You pull the lid down and ask the patient to look up. So you can ask him to do repeat 10 to 15 times in a day, in a set of 5. Another patient, this was the left eye which was operated. She was not happy because of some amount of lack of thalamus, and definitely slight amount of retraction was there. So, a week of lid massage probably solve the issues. So, as it is said that patience is the best remedy for every trouble, and किसी ने क्या खूब कहा है कि जिंदगी में कुछ रास्ते सब्र के होते हैं और कुछ सबक के होते हैं, तो सब्र करने में डेफिनेटली नुकसान तो नहीं है. Thank you.
Thank you, sir. Any comments
Yeah.
from the audience, please?
Hello. Yeah. Hi, Rajat. We're missing
Hi.
you here. Very
Uh,
interesting presentation. Were all these patients congenital or?
No, no. I think two were congenital and the rest were acquired ones. The one girl which I told was congenital and one more boy was congenital. Otherwise, were acquired ones.
Okay. And the procedure done in all of them was.
I do posterior approach. No, I do posterior approach procedures. I do conjunctival approach surgeries.
Yeah, so these all good. Your patients are able to do the massage the way you described it, because I find that it's not easy to explain to the patient how to massage. They're able to do it themselves.
Yeah, I mean, massage, it's basically you ask the patient to hold the lid margin, pull it down, and ask the patient to look up. So when they look up, the lid is pulled down by them, so it sort of stretches. So it's like a stretching exercise rather than a massage.
Yeah.
It's good.
You can also put a reverse frost suture in some of the patients if they are not able to do the massage in adults. That also works well. And I found this overcorrection in some of the, which I thought was a congenital ptosis, and it was actually a congenital, it was an LPS dystrophy. It was more like a congenital aponeurotic ptosis. And the way to distinguish that was, the down gaze, the smaller palpebral aperture. So I got one case of a really huge overcorrection because I treated it like with an LPS resection. So that's a condition we should look out for. A young person with an aponeurotic ptosis, which we don't expect in the first decade or the second decade of life.
Yeah, thank you so much.
Okay, thank you.
Dr. Rajat sir, Nidhi here. Hi.
Hi.
Good to see you. So even if there is a corneal exposure keratopathy, not so much, maybe confluent P's, would you still wait? I mean, you can put a BCL and then wait, or would you rather
exactly.
go
So
in
that-
again?
Yeah, that's what I did. I mean, lot of lubrication and the stretching exercises and a frequent follow-up, say follow up them every week and see, and if there is improvement in a week's time, probably, and the cornea is not showing signs of keratopathy, probably we can wait for surgery.
Yeah. So I've had a couple of patients. One of them had an infiltrate as well, but then it improved with the correction of the ptosis over time. And the cornea people took good care of the cornea.
You took the patient for surgery.
No, I didn't. That's
Oh,
what I'm
okay.
saying. The cornea people took good care of the cornea. They put a BCL. They kept the patient on lubricants and antibiotic, and gave the patient time and me also some time for it to come down on its own, and the patient did well thereafter. And the infiltrates also resolved.
Conservatively, yeah. I mean, Raman, you remember we had a talk a couple of times, and you two were saying that I also intend to overcorrect rather than undercorrecting or putting it on the limbus. So, I mean, this thing we have learned over the years that always it's good to overcorrect, not adjust the lid margin at the limbus. I mean, what the others prefer to do, I would like to know.
Yeah, Rajat, hi, Raman here. Of course, as Dr. Anita said, we missed your presence all over. Good to see you on screen. You are a hero of OPI, so you're always there on the screens. Anyways, yes, of course, we do overcorrect, especially in congenital ptosis. We do tend to overcorrect because they tend to reduce in height later in life, sometimes even beyond 6 months, even 1 year later. In aponeurotic ptosis, especially in acquired aponeurotic ptosis, But I have seen that even if you do appropriate correction in about a week to 2 weeks time, they tend to overcorrect themselves. So in those type of patients, then they come back. Mostly they come back. So I don't jump into conclusions, and I generally don't try to reduce it back, as I discussed in this case also when you were having this, and you remember we both were discussing, and even Raj was there. So in these type of conditions, we generally see that the patients tend to come back. It's only if they are not doing well in 3 to 6 months, or in cases where there's a lateral flare which persists. That type of cases, I do go back and readjust the LPS, because those type of cases I have seen in my experience over 20 years, they don't do so well. So those I do go back and readjust. Otherwise, a millimeter of two of overcorrections, they come back.
How often do the members gathered here see overcorrection, or what do they plan intraoperatively? Ptosis has always been an enigma. Hi, Preeti.
Hi, hi. Can I add something here?
Yeah.
That usually what I do is I give them steroids for a week so that the edema component and everything settles down. And at the end of 1 week, I decide whether I want to adjust it. And adjustment I do without any anesthesia. I feel that after a week, when you open the wound, the patient doesn't get pain, and you can without any anesthesia. If you hold, even when you want to hold the tissues, you hold inside the skin. You don't hold the skin as such, and adjust it. So I normally tend to adjust in a week's time because I give them steroid post-op.
I just give a single shot after the surgery is done. But yeah, what you're saying, probably we can try giving oral steroids as well.
Thank you so much, sir.
Thank you,
So,
Vishal. I have seen you, taking baby steps, and today is your graduation day. You have put a great show.
You have been an inspiration for me to take the oculoplasty. He is the first teacher who taught me oculoplasty.
So
during my
Vishal,
residency.
I have seen him grow. He was in double minds, when he got his fellowship with SH. I told you, go, and even if he asks to leave, don't leave. Say that I want to continue for more months with you.
Thank you, sir. Thank you, sir, for the.
Yeah, you are doing wonderful job. And other members also, your team, they've. I am extremely,
We really miss you, sir.
I've been looking forward to visit your place, your clinic, and see this meeting being hosted by you. But anyway.
वो emotional होला, bro, लाएगा क्या यार?
Yeah, Raj, Raman, enjoy, Preeti. Bye, everyone.
Bye. Take care.
So with this, we come to the end of this session. Chairpersons and the moderators and the speakers, please join us for the group photo. And we won't break for the tea break now, as we are running short of time. And Professor Rose is online, and we are very eager to witness his oration. Thank you. Yeah, we have arranged for the working tea as well. It would be available within a few minutes. As tea is the important part of our life. Yeah. So the midterm conference of OPAI is being held at Missouri at 5,000 feet. It has a story, British connection, strong British connection, and Professor Rose would have felt at home with the weather here, especially the untimely rains. Mussoorie used to be the pleasure capital of the British in India. As the organizing secretary of MID-TERM OPAI, Mussoorie, it is an honor to introduce Professor Jeff Rose, a name that is synonymous with oculoplastic surgery globally. Prolific author, teacher, and speaker, Professor Rose trained at Moorfields, where he served as Director of Adnexal Services. He has served as the President of British Oculoplastic Surgery Society and the European Society of Ophthalmic Plastic Reconstructive Surgery. We at OPAI are happy to call him a friend. He has been in the past delivered the OPAI International Oration at Jaipur 2018. But clearly, we want more. Please join me in welcoming Professor Jeff Rose. Over to you, sir. You're not audible, sir. Can you? I would request the IT personnel to.
Thank you very much. Yeah, thank you, Vishal, for your kind introduction. And it's a pleasure to join you and hear some of the interesting comments and so on. Now, just trying to get the screen right. Sorry. Excuse me a moment. Thank you very much, really. It's a pleasure to join you and really speak about the complications of orbital surgery and some of the avoidance. And at this point, with a complication lecture, one tends to thank all the colleagues who've referred their cases, but unfortunately, I can't say that. I have no financial interest to disclose. Complications basically with orbital surgery can either be intraoperative with direct damage to structures during your access to the lesion, so particularly in upper lid, levator apparatus and the fascia. Extraocular muscles and nerves can be affected. Sensory nerves, although it often leaves no deficit. Can you see the screen and hear all right, everybody? Hello?
Yes, sir.
Good, that's good. I just didn't know whether it was enough. Thank you. Blood vessel injuries, optic nerve and globe injuries, and then you can get collateral damage to neighboring tissues during removal of a mass. So you can lose the blood supply to neighboring tissues, thermal injuries and compression injuries. And then post-operatively, one can have blindness due to serous exudation, vasospasm, hemorrhage, rising pressures, infection, adhesions, and other problems. So why is the orbit at particular risk? Well, it's a fixed space, limited largely by bone, so it has no give. It's really quite difficult surgical access to certain areas, particularly the posterior third of the orbit. And unfortunately for us, the posterior third, the orbital apex, is the most crowded part of the orbit with a high density of important and susceptible structures. And there are a very large number of fine structures that require a good blood supply. And unfortunately, central nervous system derived structures like the optic nerve and so on have a poor ability to recover. So running through some of the complications, intraoperative complications, damage to the structures, the various structures that can occur. Particularly using upper lid skin crease approach, which is very useful for the upper 2/3 of the orbit, you can get damage to the levator apparatus and fascia. Now, transient ptosis is, of course, really common after surgery, and most of it is due to eyelid edema, giving a mechanical ptosis, and also, obviously, edema within the muscle and possibly hemorrhage. But occasionally one gets a neuropraxia, but almost always, if you're operating around the supraorbital fissure, one will get a neuropraxia. And that typically recovers at about 10 weeks after apex surgery. You'll get a sudden improvement in the ptosis, which has appeared stable for about 8 weeks, And then between about 8 and 12 weeks, often it'll recover entirely. So here's a patient sent me some pictures of edema, and you can see literally within days it starts turning the corner, and when things settle down, you end up with no residual ptosis. So it's purely edematous. Persistent ptosis is rarer, and it's most commonly due to an aponeurotic defect, which can either be mechanical or you can have a denervation problem. And so here's a lady with a large mass, and you can say that her mass removed intact, and she's left with a small aponeurotic deficiency afterwards. Probably that was there before because she'd had this huge mass, bigger than a globe, resting in that area for a long time. But approaching through the upper lid, we may have contributed to it. How can you reduce your damage to levator aponeurosis? Because it is a frequently used approach. Well, if you go in through the upper lid skin crease, there's a tendency always to go straight down to the tarsus as hard as possible. And that, if you carry on upwards, you'll tend to disrupt the anterior end of the levator muscle and aponeurosis fibers. So I tend to encourage people to pass up in the suborbicularis space and try and keep in front of the septal condensation rather than getting into the deeper fibers. So I try and avoid damaging the upper part of the tarsal plate. Keep under orbicularis, you can see it under direct view, and then don't head back straight away. Head out towards the marginal area so that you go through septum away from this levator apparatus to reach masses. And again, when you're dissecting, try and dissect tangentially alongside masses. You tend to get them out more easily with less collateral damage. And so, for example, you know, a deep intraconal varix, thrombosed varix, and you can remove the mass really with very little damage to the neighboring tissues. Likewise, here, a child with a ptosis due to a large cystic mass within the levator apparatus. By carefully keeping close to the lesion, you can remove the whole mass intact without disturbing the main fibers of levator. And here is the child only a few weeks later with absolutely no residual ptosis. So you can avoid damage by really keeping close to the mass and avoiding damaging the area with the fibers on the tarsal plate. Clearly, you can end up with a partial or complete palsy if the mass has involved the system, you know, the nerves to the levator and so on. And this can occur obviously to nerves elsewhere as well, for example, facial nerve. But it doesn't have to be, although you can get a pupillary response. Here's a mydriasis secondary to resection of a huge optic nerve, glioma, and it's the only residual deficit, but clearly unavoidable. Frontalis branch palsies for huge masses like this one, a huge neurofibroma extending out into the temporalis fossa. You know, absolutely huge lesions, sort of 6 or 7 centimeters long. To get this sort of lesion resected and a satisfactory lid position and tidy up, unfortunately, the frontal branch of the 7th cranial nerve suffers. And in retrospect, probably I would have done an internal fixation at the time. Periorbital sensory loss is not uncommon, but often isn't that troublesome. So you can have, there's a small blood vessel crosses between the orbit and the infraorbital nerve, and to work along the orbital floor, you actually have to diathermy that vessel that crosses, otherwise it can bleed rather markedly. It's typically medial to the infraorbital nerve, and that can lead to a temporary numbness of the cheek. Or if you have to debone it for a really large decompression, you may end up with a numb cheek, which doesn't recover in a few percent. Most people it does. Likewise, doing a lateral fenestration for lateral decompression, you do pick off twigs of the sensory nerves. And if you really test carefully, they may have a tiny area of a square centimeter or two of numbness on their temporal area. Clearly, damage due to the orbital vasculature, but especially around the apex, for example, the ophthalmic artery arching over the optic nerve. On the other hand, you can remove huge masses like this one from the intraconal space and end up with really good function, both visually and motility-wise. So unfortunately, yes, they are at risk and you have to warn the patient, but not inevitably so, thank goodness. Second group really are those due to collateral damage, in other words, where those tissues that get damaged alongside the main area of injury. And this can really occur due to a loss of blood supply. It can occur due to thermal injury or compression injury. So, for example, when you've got absolutely massive masses that are compressing everything down into the residual part of the orbit, as seen here, these are all the normal structures tucked in there. Otherwise, it's mass all the way. And the patient had gross proptosis and hypoglobus. With resection of this mass, unfortunately, the patient lost vision or markedly reduced vision due to a mixture really of compression and probable ischemia. How can you reduce the chance of collateral damage due to thermal damage whilst you're operating? Well, the first thing is use bipolar cautery deep within the orbit, not monopolar, so you're not getting current flow through other structures, only between the tips of the bipolar. The second thing is keep your diathermy time relatively short, because once you start diatherming, even with bipolar, you are generating a very high temperature between the tips, and the neighboring tissues will conduct that heat away. And the longer you apply that heat coming in, the greater will be the spread of collateral thermal damage. So keep duration of diathermy brief, relatively brief, and repeat it if necessary, giving the tissue a chance not to get too much spread of heat. The third thing is use malleable retractors to protect structures that are susceptible to heat, and also they will act as a heat shunt to dissipate local heating. The third area where you can get problems is due to compression of tissues. For example, in this patient with sphenoid wing meningioma, where we're doing a medial decompression, whilst you're moving the structures laterally, the pressure in this area was sufficient to cause a ciliary paresis. So the patient had an enlarged pupil after surgery, which gradually recovered and became, in fact, slightly supersensitive afterwards. So it's a transient injury due to ischemia, due to compression with the retractors against a bulging lateral orbital wall. Interestingly, I have never had that in many hundreds of medial decompressions where I've gone to the apex. It does seem to be where you're in the area of the tissue that gets involved, the ciliary ganglion, rather than the apical optic nerve. Postoperative complications, blindness, serous exudation, vasospasm, hemorrhage, rising pressure within the orbit, infection, adhesions, fibrosis, ischemia, and hypoglobus. Now, this is the sort of patient I really worry about, the patient who comes in and says, my vision's failing on the left side, and you see almost nothing. Patient sees nothing or almost nothing, you see almost nothing. Just very subtle displacement, and it's typically due to this sort of small peanut lesion wedged in the apex, and they do have an increased risk of complete visual loss after surgery. Overall, it's not that, it's still a minority chance, but the patient needs to know that they've got a good chance they'll improve from count fingers to 6/9 in about 90% of cases, but they may end up with non-perception of light. So what really are the possible mechanisms for this loss? Well, direct optic nerve laceration, in practice, that's actually jolly difficult to achieve. The optic nerve is surprisingly strong, and you wouldn't do it without noticing that you're damaging it. And there aren't really any signs of having damaged the optic nerve in the patients where I've lost vision. Second is transection of the ophthalmic artery, and it is at risk of apical dissections, particularly below the optic nerve, around the apex. But it's very evident if you pick off an arterial branch in the deep orbit, it certainly bleeds on you, even with hypotension. And interestingly, of the patients in whom I've had visual loss, they've never had central retinal arterial occlusion at the end of operation. I always check after deep orbital surgery to see whether the optic disc is perfused. And we've shown perfusion to be present in all such cases with digital pressure on the globe whilst watching the disc. And so damage, it's probably further forward, and it's probably compromising the optic nerve due to ischemia. Now, here, for example, it's almost certainly due to vasospasm. So here, for example, a straightforward cavernous hemangioma. And here is the patient a day after surgery. You know her back of her eye was all right at the end of surgery, but here she is with about 2 to 3 millimeters thickness of retinal edema. And here she is having fluorescein angiography on day 1, and she's only just filling the choroid after about half a minute. So the choroid is highly ischemic. She's only starting to fill her central or her retinal arterioles in the 100-second phase of the fluorescein angiogram, and she still hasn't finished them and entered the venous phase by 400 seconds. In other words, there's almost no blood getting to the eye, ophthalmic arterial spasm or transection. So here she is 2 months later with a clear atrophy of very poor non-perception of light. But if you look at the ophthalmic or the retinal artery on that side at 2 months after surgery, it's as arterial flow, and it's actually better than its partner side. So we clearly haven't transected it or diathermic the vessel. It's clearly spasm in the first 12 hours after surgery that causes this gross ocular ischemia. So what is it that probably causes the vasospasm? Well, it's almost certainly either direct trauma with striking the vessel, compression of the vessel, or distortion of the vessel, and inflammatory vasospasm. We know that things like thrombin and the inflammatory mediators are potent vasospastic agents who cause gross arteriolar narrowing. And so if one injures the vessel with a direct blow or pressure, you get an area of spasm in the vessel which will reduce distal flow, and you end up with a very poor flow. This spasm will last for a while. And the clinical evidence really is that the intraconal surgery at the apex, whereas extraconal surgery, where you don't get access to damage to the artery directly, you don't see this sort of visual loss. And it is commoner after difficult dissections and so on. And basically, blindness is really due to the optic nerve compromise. How can we reduce the risk of blindness? Well, recognize obviously displaced normal orbital structures, for example, the arteries and so on. Avoid handling the optic nerve. In other words, if you keep a layer of fat over it, I prefer not to see the optic nerve whilst I'm operating. But if you do see it and you have to apply retraction, make certain that you have gentle retraction and relieve tissue pressure during surgery. Make certain, as mentioned earlier, that you use bipolar surgery with short pulses so you don't get collateral thermal damage, which can cause arterial spasm, and avoid using absorbable hemostats, sort of oxycell and so on, in the apex of the orbit. It's thought that they can absorb fluid and blood and retain inflammatory mediators, as well as increasing the pressure at the apex. And the third thing is place a drain with all orbital apex surgery. And I use these little mini vac drains. They're ideal for the amount of fluid that one tends to drain out. And I place the drain right back to the orbital apex to remove inflammatory mediators. And last of all, I always give high-dose systemic steroids during surgery and immediately after surgery. Calcium channel blockers, nimodipine and so on, we know that the ophthalmic artery is a central nervous system derived artery, and we know that nimodipine works for arterial spasm during subarachnoid hemorrhage. The main cause of morbidity with subarachnoid is arterial spasm. So nimodipine is used. Now, I have tried it. The trouble is the instance of visual loss is relatively low, and so it's hard to know whether calcium channel blockers will help, but certainly it's worthwhile considering. carrying on really. So that's visual failure, orbital hemorrhage and rising pressure, things like post-redo decompression or other causes anterior hemorrhage. First of all, I pad all orbits. I know it's a contentious issue, but I pad all orbits at the end of surgery because the commonest cause of course, of swelling is venous or capillary bleeding or ooze, leakage of vessels. And if you just keep a firm pad, not to arterial pressure, but firm, it just reduces the amount of oozing into the tissues, amount of fluid leakage. And that leaves more space if you do get an arterial hemorrhage before you wipe the vision out. Arterial hemorrhage, and I have seen it, causes severe and increasing pain. There's no mistaking it. The patient will be rolling and will say, gosh, this is incredibly painful. And if a patient says, I've got really severe pain, you need to check the vision as a matter of urgency. And if the orbit is rock solid, then you need to intervene. So if they have a tense orbit with increasing signs of visual failure, try firm pressure to start with. If it's on the increase, this may stop the bleeding, but if it still increases, open all the incisions and spread into the tissues, and you generally will get leakage. And if that still isn't enough, perform canthotomy. Basically, canthotomy, a quick reminder, it's a little bit of local anesthetic in the canthal area, horizontal canthalysis, and then division all the way up alongside the margin so that you divide the septum and the limbs of the canthal tendon. You just don't want to do the limbs alone. You want to make certain you open widely. And if your juniors are struggling to do it, you can tell them to open the skin as well, along the skin fold. Other causes of problems, infective orbital cellulitis, there's not really much to say about it apart from good technique. And occasionally one will see necrotizing fasciitis following surgery, although I haven't ever seen it myself. I've seen cases. Adhesions and fibrosis following orbital surgery, basically here is patient referred after removal of dermolipoma. And the problem here has been that there's been disruption of the Tenon's sheath around the lateral rectus, which should not be disrupted if you can avoid it. And likewise here after lateral orbitotomy, a problem due to lateral rectus adhesion. Not a big problem, but enough to be troublesome. Another area where it's not uncommon is this sort of patient who was referred following several explorations of the orbital floor to repair a fracture, and they have an adhesion of the conjunctiva and the lid down to an exposed implant, and it had been left for a long time, which of course doesn't help at all. Once an implant is exposed, that will not heal. It should have been dealt with long ago. Unfortunately, it was compounded by their having placed the implant through the lacrimal drainage system as well. And basically, if you are having to deal with an extraconal mass, do not go down through the low fornix, which is effectively they've tried to reach the orbital floor through, if you're trying to reach the orbital floor, don't go down through the lower fornix. That's what they've done here. They've gone in the low fornix, the low variant of the flap. You should use the high variant, what I've termed the high variant of the lower lid swinging flap, where you go a millimeter below the lower tarsus, down in the anterior to the septum, and then into the floor that way. That way you don't get an adhesion because you do not disrupt the fat in that area. So orbital floor explorations or removal, use the high variant of the flap. Only use the low variant where you want to reach the intraconal or extraconal space. Periorbital tissue necrosis, ocular ischemia, is relatively rare, but you get necrosis of bone, necrosis of skin flaps following radiotherapy and so on, or even full necrosis of the lateral wall in an accentuation where there had been previous radiotherapy. Or you can get osteonecrosis for no apparent reason in a diabetic here, the remaining rim that we left following a decompression for thyroid eye disease just carried on discharging because it became ischemic. How can you avoid ischemic necrosis if you're doing a lateral osteotomy? Well, nowadays, in the past, we used to lift the bone out, put it into a pot, drop it on the floor of theatres, and wonder why it gave us a problem. Now we no longer remove the bone. What we do is we swing the bone out, but leave it on temporalis. So you cut through temporalis and diathermy posterior to the incision, so you can swing the bone out and it never leaves the patient. And then repairing it is much faster. You just swing it back into place, suture it in with a 4-0 or 5-0 soluble suture, close the periosteum over it, and it does extremely well. And you don't get ischemic changes and malposition, and you don't need metal or anything to hold the bone in. Last sort of decompress problem really that I've seen is the late postoperative hypoglobus. It's rare. So for example, here a chap, he's done very well following, he's gone back to within a millimeter. Afterwards, he's gone back about 11 millimeters. And so here he is immediately following surgery. He has an amblyopic eye, but he has his squint surgery at 6 months. But then at about 18 months, he pitches up saying, no, my eyes become sunken. Okay, so you get, sure enough, it's not only enophthalmic, it's become hypoglobus. So what has happened here? Well, with decompression, the normal fundal aeration, it's our approach. The clue was in 5 out of 6 patients that had this, that it was left eyes mainly. I used going across the floor at that time to decompress the medial wall and the floor. And on the left side, because I'm a right-handed surgeon, I was causing more injury to the maxilloethmoidal strut here, this bone. And so that's why the left eyes were getting damaged more than the right. And maxillary aeration depends on this ethmoid infundibular area. It needs to be kept clear to allow aeration. So what was happening is, on this side, which we didn't need to decompress, his aeration continues as normal. But on this side, the fat prolapse, here is the late postoperative scan, has brought the fat down onto the area where he should be aerating this maxilla. And so he loses the aeration of the maxilla, which in turn then contracts like glue ear. So how do we prevent it? And I've never had a case since this prevention, which is basically to leave the anterior half of the infromedial bone strut. So here is the ethmoidectomy site. Here is the floor removal. That's the strut between the maxilla and the ethmoid, or the infromedial strut. We remove the posterior part up next to the canal, the posterior half, but we leave this anterior part so as to support. And what that does is it prevents the fat prolapse in the anterior part. And if you look through area of removal of the floor, you can see we removed the area there, but it prevents the fat prolapsing down in patients. And that is the antrostomy, or the antral aeration site, looking from inside the antrum outwards. So complications with orbital surgery, we mentioned the intraoperative ones and ways to avoid damage to various structures. Collateral damage, to try and avoid damaging blood supply, but particularly thermal injuries, compression injuries, post-operative problems, which we've mentioned and run through, and how to avoid them. So thank you very much, everybody, for your attention. And I trust that you're having a good meeting in a wonderful location. Thank you very much.
Thank you, Professor Rose, for the wonderful presentation and insight on how to prevent the orbital complications. I'm sure that my colleagues here are eager to connect with you with their questions and discuss with you. Yeah.
Thank you.
Hi, Prof. Good evening. This is Amrita.
Hey, Amrita, how you doing?
I'm well. How are you?
Good form, good form. We've actually got good weather for once.
Yes. Hi. Long time. So, Prof, my question to you is, you had mentioned a case where there was a peanut lesion with a minimal proptosis. Do you, first of all, think about just observing it, like we had discussed multiple cases before also? Do you think we should wait if the vision is not affected or the patient has 90% vision, residual vision. Is observing one of the ways, buying
Yeah.
some time?
Yeah, absolutely, Amrita. You know, very sensible question, because you are always balancing risk against benefit. And in patients like that, if they've got really severe vision loss when they come, you know, when they're 624, 636, 660 with an obvious field defect and very poor color vision, they've got very little to lose. And I tend not to wait for that sort of patient, because they can suddenly snuff out vision. But if they come with 6'9", 6'12", reasonable color vision, you know, almost all of the plates, and minimal or no RAPD and minimal field defect, I completely agree. I would wait and repeat the measurements. And if they're showing progression, you've got a much better reason for discussing surgery with them and the risks of visual loss. Completely agree. You need to show progression, or if they have very severe deficit, then I will go in earlier. But absolutely right.
Thank you, Prof. Just have another very small question about dotatate scan. Do you have any experience with the dotatate scan in such lesions which are near the optic nerve?
Yes, I mean, dotatate, is useful. Obviously, its uptake in about 90% of meningiomas. So you're really using it only where you think, is this an exophytic meningioma of the optic nerve? Because sometimes those apex lesions, it can be hard to tell. You know, the one I showed was clearly a peanut, but if it's a more fluffy lesion, is it eccentric optic nerve meningioma or not? And in those cases where clearly surgery isn't going to be of any great benefit and it's not a good idea to biopsy them, the dotatate scan definitely we would use. And if it shows avid uptake, it tends to be meningioma. But 10% of meningiomas or so don't take up dotatate. So there are a few that will be left not picked up that way.
Thank you, Prof. Nice to see
Yeah,
you.
thanks, Amrita. Nice to see you.
Any other questions?
I think they want their tea.
Dr.
Hi, Dr. Rose. I'm Fairuz here.
Hey,
Nice to have
Farouz.
you
Hey,
here.
how you doing?
I'm good. Nice to see
I saw
you.
you in the back earlier on. Because the camera's been spying on you all.
It's an amazing talk. I mean, great learning as always. So sometimes after a large orbital lesion in the lateral orbit, you know, although you know that you have not touched the optic nerve, way away from the optic nerve, but then, you know, you get an anisocoria the next day. So have you seen injury to the ciliary ganglion, which can cause an anisocoria in these patients?
Yeah, absolutely right. The infralateral and lateral area, where of course cavernous hemangiomas are the commonest site, that sort of area, lateral, infralateral. It's not uncommon to see a degree of pupillary change during surgery. Now, pupillary expansion during surgery tends to be due to 2 or 3 things. One is pressure on the globe. With pressure on the globe, you definitely get a moderate degree of mydriasis. You know, it'll expand to 4 or 5 millimeters, and you take the pressure off, and within a minute or so, it comes back. And I think that's purely a change in anterior chamber depth, you know, in aqueous dynamics. Second is that you actually are getting true ischemia, as you mentioned, and you can get a sectoral mydriasis and so on, where you can quite clearly see the pupil coming out to 7, 8 millimeters diameter, either as sectoral or completely. And again, I would take the pressure off, give it 5 minutes rest, go for a cup of tea. Well, maybe not, but you know, give it a chance to recover. And most of those will recover. And I think that is pressure on the ganglion. And then the sort of third one is where it goes bang and the pupil gets big, and you know that something has gone, either ischemia has knocked off the nerve, and you go groan. And yes, quite a number. If you look carefully at the pupil afterwards, from masses lateral to the nerve, about a third of them, when they're taken out, cavernous hemangiomas will have abnormal sectoral contraction. You know, on the day after on the slit lamp, or a noticeable mydriasis, but almost all of them recover. And we actually wrote a paper on a very large number of pupillary defects after. Luckily, most of them recover, but about 10% will have some slight deficit. So how many times have I seen this ciliary ganglion? To be honest, out of thousands of times in the orbit, I think I've seen it once, where I could actually say, I think that's the ciliary ganglion. So Dia knows where it hides. It's like hiding in the, in the pillowcase, hidden in the floor.
Yeah.
Thank you, though.
Thank you. Thank you so much, Dr. Rose.
Any more questions?
Vishal, they must be up after tea.
No, sir. It was a wonderful presentation, and it was great to hear you. It was an honor for every one of us. Thank you so much for joining with us. And
thank you for asking us.
Maybe
it's always fun.
Maybe in near future, we'll invite you back to India again. Thank you.
Thank you very much, everybody. Thank you.
So can we have a quick group photo and proceed for the next session? Sabka group photo. The entire delegates. नीचे जाके आते जल्दी से आते नहीं खाली है बारिश नहीं है Is it raining? So we can do it here. We can do it here. We can, yeah, please join us. Chair में थोड़ा सा कर देता हूँ. अरे क्या था पीछे Please join. We can just turn the chairs so that seniors and like वैसे उधर हाँ नहीं ये नहीं हो पाएगा उधर कर लेंगे ये बिट्टा आ जाएगा ना ये बिट्टा शायद नहीं आएगा इसका इल्यूमिनेशन थोड़ा कम हो जाएगा इसका इल्यूमिनेशन कम हो जाएगा नहीं जो बंदी फोटो है कुछ लोग बैठ जाएंगे Please join.
सर आप लंबे उधर आ जाओ ना लंबे लोग पीछे आ जाओ सर लंबे लोग पीछे आ जाओ सर आप भी आ जाओ सर
Hello.
So let us proceed with the next session within 2 minutes. Let us settle down. And I would again request you all to please visit trade. To encourage our trade partners, they have been very generous and helpful to us for this to organize this conference.
I went there, but that's closed. Tomorrow. Yeah, tomorrow we'll go. We should definitely go tomorrow.
So our first presenter is ready online. Yeah. And I would request the chairpersons and the moderators to join us to start the session. I believe Dr. Honawar is online. Sir, नहीं मेरा phone है. So Dr. Megha is ready with a presentation. And I hope Dr. Honawar is also online to chair the session online. And we have esteemed guests here as a chairperson, Dr. Anita Sethi ma'am, Dr. Rajesh Tiwari sir, Dr. Saurabh Luthra sir, Dr. Abhijit Kaur ma'am, and Dr. Feroz, and Dr. Akshay. And moderator, this session is being moderated by Dr. Sukhdeep Kaur and me. So we start with the first presentation by Dr. Banka Megha.
Should I share my screen, sir?
Yeah, please.
Okay. Is my slide visible?
Yes, please go ahead.
A very good afternoon to one and all, and a huge shout out to the organizers to accommodate all of us who could not be there. I'm Dr. Banka Megha Ajay, and today we explore if topical chemotherapy in sebaceous gland carcinoma is a hit or a miss. 57-year-old hypertensive male presented to us with pain, redness, and left upper lid swelling since 5 years. He was treated as chronic blepharoconjunctivitis for almost 6 months, but on further deterioration underwent an incision biopsy and was referred to us as histopathologically confirmed pagetoid sebaceous gland carcinoma. On examination, we note diffuse conjunctival congestion involving the entire upper palpebral conjunctiva, a thickened lid margin, meibomian gland dropout, and telangiectatic vessels. The bulbar conjunctiva clinically looked uninvolved, and there were no palpable lymph nodes bilaterally. A 17-site conjunctival map biopsy confirmed the extent of the pagetoid component. Thereafter, a trial of mitomycin had to be discontinued due to poor patient tolerance. With this confusing picture due to no clear demarcation of the tumor extent in the palpebral conjunctiva after an abrupt course of mitomycin, there was considerable risk in doing an eyelid sharing surgery. Hence, we repeated a map biopsy, and after a negative result, we proceeded with excision biopsy under frozen section control with cryotherapy, and then lid reconstruction with cutler beard surgery. For about a year and a half after that, the patient had an uneventful follow-up in close monitoring with a cornea consultant for a mildly irritable eye, till we noted severe papillary hypertrophy in the entire span of the upper palpebral conjunctiva and repeated a map biopsy, which confirmed recurrence of pagetoid sebaceous gland carcinoma of the papillary variant. After a reassuring PET CT, at this point, orbital exenteration seemed reasonable due to prior suboptimal response to mitomycin and unjustified ocular surface damage, leaving no useful vision with EBRT. However, on patient's very keen insistence at eye salvage, we made a final attempt with modified 5-fluorouracil topical chemotherapy with bandage contact lens to aid patient tolerance and counseled him for strict close follow-up. After 6 cycles of 5-fluorouracil, we can appreciate excellent response with near total clinical resolution, which was confirmed on a map biopsy with just the superotemporal fornical conjunctiva positive for malignancy, which was treated with a heavy triple freeze-thaw cryotherapy. And 3 more cycles of 5-fluorouracil were advised, followed by a repeat map biopsy, which showed no evidence of atypia at 6 months follow-up. Think pagetoid sebaceous carcinoma, think conjunctival map biopsy to confirm the diagnosis and the extent. Alan Putterman suggested that map biopsy helps to prognosticate and chart the further plan of action. Due to its aggressive and stubborn nature, pagetoid sebaceous carcinoma often comes as a grim indication for exenteration. However, today we have multiple studies in support of topical chemotherapy like mitomycin and 5-fluorouracil with excellent globe salvage rates. In the 2018 IGO editorial, Dr. Santosh Navar asked if we can do better with sebaceous carcinoma. It is 7 years to the question, and the answer continues to be yes. A customized approach while respecting the oncological principles is key. Sebaceous gland carcinoma of the pagetoid spread is the great masquerader capable of arising from multiple structures and confusing majority comprehensive ophthalmologists. It's the most common eyelid malignancy in India and has for the longest time caused globes and lives of many unfortunate patients. In light of today's strong evidence-based practice, it is not only wise to use measures like conjunctival map biopsies, but also give our best shot at newer conservative modalities before resorting to something as drastic as exenteration. We miss all the chances we do not take, and hence we must take them more often than we do. Thank you.
Wonderful presentation, Dr. Banka.
Thank you.
Any questions by the chairpersons? Meanwhile, Dr. Anurit, please be ready for the next presentation.
And that was an excellent presentation. You used multiple techniques, and I think you really got a good result. Did you say the patient lost vision?
No, the patient's vision is all right. His cornea was there was a little bit of corneal epithelial defect, which persisted because he could not tolerate mitomycin very well. But then he recovered from that, and he was much more tolerant to 5-fluorouracil.
And you also gave him a BCL. So I think that was really, you did cryo, you did the map biopsy, you tried the non-surgical, the medical treatment as well. I think it's an excellent management.
Thank you.
So next presenter is Dr. Anurit Kaur.
Good evening, one and all. The topic of my presentation is lessons learned the hard way. So if a patient presents with painful blind eye, what is the first thought on management?
Let's keep our thoughts held till the end of the presentation. I would like to present a case of a 7-year-old boy who presented with a history of trivial trauma to right eye, underwent lensectomy elsewhere. He came with complaint of pain, diminution of vision, and cosmetic concerns in right eye with visual acuity of counting fingers. Later on, he developed secondary glaucoma with glaucomatous optic atrophy, which was medically managed, had painful blind eye, and had to undergo right eye evisceration with implant under GA. The histopathology came out to be normal. We came across two problems in the case. First one was an ill-fitting prosthesis, and the second one was a soft tissue mass which was palpable and superior migration of the implant. So we went ahead with contrast-enhanced CT scan of the orbit, which showed heterogeneously enhancing mass in inferior and lateral part of the orbit with superior nasal pushing of the implant. We went ahead with incision biopsy, and there were multi-layered neuroepithelial cells in form of ribbons with a background of myxoid stroma. There were cells with atypia in islands of hyaline cartilage. Also, IHC marker, it was immunoreactive for vimentin, GFAP, and synoptophysin. So the twist here was the patient came with painful blind eye with ciliary staphyloma. Who had to undergo evisceration. There was a recurrent mass, and there was repeat incision biopsy findings, which was suggestive of atypia. And it turned out to be malignant teratoid medulloepithelioma. So we asked the patient to undergo PET CT scan and started him on chemotherapy. However, he was lost to follow-up, and he came after 3 to 4 months with further local spread. There was presence of lymphadenopathy, so he had to undergo exentration with chemotherapy and radiation. So on hindsight, there was an indication that there was post-traumatic subluxated lens with ciliary staphyloma and secondary glaucoma, which are a few of the clues that could be missed. And early tumors are often missed on B scan unless we undergo UBM to see the ciliary body area. On reviewing the literature, these patients present late as they masquerade as cataract, glaucoma, or uveitis, and 88% of them could be misdiagnosed. The prognosis stays excellent. 5-year survival rate is 90 to 95% after enucleation. According to the paper, if there is extraocular extension, there could be 12% tumor-related deaths. If there is extraocular extension, which is rare, it is suggestive of high risk of metastasis and poor prognosis. So take-home messages: examination of ciliary body area is very crucial. The patient had to undergo ultrasound biomicroscopy and B scan. It is must in all cases. And enucleation is preferred over evisceration if a child has doubtful etiology. Coming on to our first question, is it an end-stage disease? Not always. We have to keep in mind that there should be a high index of suspicion, and we should rule out intraocular malignancy, especially in a child. Thank you.
Wonderful presentation.
Thank you.
Any questions?
What do you think was the primary cause of the ciliary staphyloma?
Ma'am, it was a hidden tumor, which was not
That's all right. But was that ciliary staphyloma addressed in any other form? In the sense that, was there evidence of ophthalmos? Was there any, because you said that there was a subluxated lens.
Yes, ma'am.
So probably the primary examination of this child,
yes, ma'am,
had overlooked these issues.
Yes, ma'am. The child was referred to us actually after.
Excellent case presentation. So whenever a pediatric patient presents with one unilateral secondary glaucoma, unilateral cataract, unilateral staphyloma, the things that we always keep in mind is ciliary body medulloepithelioma and retinoblastoma, of course. Now, this staphyloma that you see here probably is because of the previous surgery that has been done and raised intraocular pressure. So ciliary body medulloepithelioma is very, very common to present as secondary glaucoma in these children. So there has been a surgery done and intraocular pressure, which led to that staphyloma over there. So ideally, the teaching is in ocular oncology, any pediatric, even adults, you have to rule out. In such a scenario, always enucleate, never eviscerate. Yes, never eviscerate. Yeah, that's great learning. Thank you.
Thank you.
One question, can I ask?
Yes, ma'am.
Yeah. So in most of these cases who come with staphyloma for painful or painless blind eye for cosmetic improvement, we do a B scan for all the patients. But do you also do a UVM for all the patients? Because in a child, it's going to be really difficult. Is that what is recommended?
Preeti, if you don't have a history of trauma or staphyloma in a child, it's good to investigate really thoroughly. And ciliary body medullary epithelioma is something which comes near the limbus and anterior globe. So well, yeah. So it's important. But
maybe MRI would be better than UVM because UVM I think is so much.
No, MRI, it's very difficult to identify a small tumor in the ciliary body most of the time. Ultrasound B scan is enough in these situations. But overall, whatever you do, it's better to do an enucleation, to be safe. Yeah.
And yes, OCT can also play a role if you don't have access to a UVM. Because an OCT does show that area of the angle and the posterior part, the anterior part of the ciliary body.
Did the histopath of the eviscerated specimen show anything?
So that was not.
Did you review that again?
Yes, sir. That was not.
So then it got that case, the orbital seeding could have happened at the time of the first lensectomy, because whatever you've removed
that was,
doesn't have any tumor.
Mm.
Or it could be
this.
Yeah.
The sample that they sent,
Usually,
yeah,
yeah.
so it's been missed because evisceration sample, not everyone actually looks into. So possibly it's a misdiagnosis of histopathology. Yeah.
Well, I also have a question from expert. Can there be some role of PET scan in such cases?
Small lesions, and especially in a post-operative case, inflammatory tissue also picks up signals. So I don't really think that for a ciliary body tumor, PET is the answer.
Metabolically very low activity, okay, 67 or mitotic activity will be very low. So uptake of the dye, the 16-FDG will also be very low.
I think enucleation in any child is probably just the best way to go about it.
Thank you.
So I call upon next Dr. Ashwita Alva. She's online.
Sir,
Hi.
I'll just share my presentation. Is it clear?
Yes.
Okay. Very good evening to one and all. I'm having a great moment just online, missing out on what is really happening there. Thank you to the organizing team for involving us, though we were not personally there. So Cox or SARS, two names, two distinct identities, they appear to merge seamlessly. Let's dissect how. One fine morning, a 26-year-old male walked into our OPD, vexed with this prolonged duration of redness and severe pain. Taking several steps back, we found that he had extrapulmonary Cox, also treated on antitubercular medications, and 4 years later, he developed this redness and pain in the eye. He was diagnosed with right eye nodular scleritis elsewhere, started off with an absolutely good vision of 6/9, and in the backdrop of ocular tuberculosis, he was started on steroids and antitubercular medications with the evidence of MANTO being positive and AC-TAB being positive for MPB464. The B scan showed choroidal elevation and scleral thickening and subtenon's fluid. Post 2 months of the treatment, clinical features still worsened and the visual acuity dropped to 6/60. Retinal examination showed right eye subretinal tubercular abscess. He was treated with intravitreal antibiotics, and 3 months later, a TB PCR on the vitreous biopsy was negative. 9 months later, he came to us to the OPD, a diagnosed case of ocular tuberculosis, visual acuity as low as no light perception, complete ophthalmoplegia while on ATT medications with no signs of resolution at all. The right eye was thusical, however, not enophthalmic. That mandated an orbital imaging to reach the conclusion. On MRI, we found a well-defined soft tissue mass covering the entire orbit, encasing the orbital segment of the optic nerve and grossly involving the right lacrimal gland. Also, the anteromedial aspect of the globe had a mass. Right-sided proptosis with this mass causing a compression, distortion, and infiltration of the globe was seen. On the basis of a clinico-radiological judgment, we went ahead with a multi-level incisional biopsy following a steroid washout for 3 weeks. On histopathology, we found marked lymphocyte and plasmacytic infiltration and fibrosis with areas of hyalinization. Immunohistochemistry helped confirm the same, seeing 45 IgG4 plasma cells per high power field. As all the three criteria of clinical, hematological, and histopathological diagnosis was confirmed, we diagnosed the patient to be a definitive IgG4 related disease and thus started the patient on intravenous methylprednisolone with a loading dose of 3 consecutive days of 500 mg and a maintenance dose scheduled 3 weeks apart. After the 6th cycle, the IgG4 levels were still found to be high and thus was shifted to immunomodulation with mycophenolate mofetil 1 gram per day. This is a post-treatment clinical picture, and the MRI picture also shows that the proptosis resolved completely with enophthalmos setting in, and there was a near total resolution of the soft tissue as well. Post all the treatment, we did a right eye enucleation with implant by minimal manipulation myoconjunctival technique, following which a tarsofrontalis sling was done for an excellent cosmetic outcome. The case started with a twist, a diagnosed case of ocular TB with evidence from several premier institutes and ophthalmologists, yet a worsening disease, questioning the diagnostic value of TB PCR. This meta-analysis showed that the overall sensitivity was 88%, however, the specificity was low to moderate, that is 71%. Going by the algorithm of an approach to a case, the clinching feature which helped in our diagnosis was that the suspicion of a mass pushing the globe forward. Despite the eye being thusical, there was an underlying mass, and thus this was the differential diagnosis we had. On your screen, we have the pole-to-pole manifestations of IgG4-related disease all found in our patient. Scleritis, anterior uveitis, vitritis, subretinal infiltrates, a choroidal mass, complete ophthalmoplegia and ptosis, dacryoidinitis, a radiological imaging showing diffuse infiltrative pathology, and as the lid coffin, the final is the histopathology. The disease mimics a broad spectrum of clinical entities ranging from neoplastic to inflammatory and even infectious conditions. Baseline radiological imaging followed by surgical biopsy is to be done. Early diagnosis and treatment with steroids and immunomodulators aids in an excellent outcome. Thank you.
Nice case, Dr. Ashwita.
Thank you, sir.
Chairpersons, any comment?
Very interesting case. I just had a query that the PCR you said was positive. So in this case, which had completed a course of ATT in the past, how would you, account for a positive PCR and, finally it didn't turn out to be a TB case? So what was the reason for a positive PCR from the, from the aqueous, I think?
Yeah, that's why I went through a couple of studies, and it says that the specificity is only 70%, and some even said 60%. And some studies also show that if a patient have extra pulmonary tuberculosis, then fluids like aqueous humor or vitreous tap can be positive sometimes. However, it doesn't confirm of an ocular tuberculosis. This was what was, I think, confusing even to begin with when he did not come here and the treatment was started.
Probably the vitreous aspirate would have been a better fluid to, do the PCR, because aqueous can be misleading. Yeah.
Misleading. Yeah. In fact, the second vitreous biopsy which they did after the prolonged treatment, of course, was negative for tuberculosis.
Thank you.
So we will move on to the next presentation by Dr. Priyanka Valvekar.
A very good evening, everyone. This is Priyanka here, and I will be taking you through this case of conjunctival pigmented lesion, which is occurring metachronously in the eye. So as we all know that pigmented conjunctival lesions can range from benign freckles to potentially life-threatening melanomas. And broadly, we can classify them into benign or malignant. And again, they can be further divided based on the melanocytic involvement into melanocytic and non-melanocytic pigments. So for just a brief overview about the presentation of commonly encountered pigmented conjunctival lesions, we have the nevus, which has a more long-term presence. These are just key points for each of these pigmented lesions, and they show a change with hormonal surge. They are usually presented with intralesional cysts, which can be picked up on an ASOCT, and they have slightly variable pigmentation. Complexion-associated melanosis is usually bilateral. They have dusted pigmentation, and they're seen in dark-skinned individuals. And primary acquired melanosis, or nowadays the preferred term would be semen, that is usually unilateral. Waxing and waning is associated with homogeneously pigmentation, which is common in light-skinned individuals. And conjunctival melanoma have classic features of nodularity, immobility, vascularity, and variable pigmentation. So usually the cell of origin is melanocyte, and as you can see, they are based on different morphology. They can be dendritic, nevoid, and fusiform. And just to take you through this primary acquired melanosis, it is a clinical descriptive term which is given to flat pigmented lesion, which is confined to the bulbar conjunctiva most commonly. It can be diffuse or multifocal. In the image to the right, that is nothing but a nevus, and that is usually treated with an excision. So now significance of monitoring these lesions is that most 11% of them can develop into melanoma within the first 10 years of appearance, 2.5 years being the median, and about 53 to 75% of them arise from a pre-existing melanotic lesion with atypia. So with this background, let's look at this case, which our case with the twists and turns. So we had this 40-year-old gentleman who presented to us. Who presented to us with almost a 6 clock hour involvement of pigmented lesion. And there was a 0.5 millimeters of limbal free zone. It was slowly progressive over the temporal bulbar conjunctiva, and there was a small area of limbal free zone. Now, post this, he was advised excisional biopsy followed by an AMG, and he underwent the same, explaining to him about the prognostication based on HPE analysis. And his histopath examination revealed a compound nevus. Now, a compound nevus is usually a type of variant which involves both an epithelial as well as a stromal component. And it is so called because it has both of these components. So he was advised a close follow-up. And in the second chapter of his visit, he came to us almost about 2 years after having a loss to follow up. And this time he presented to us with a lesion which was almost involving 2/3 of the upper palpebral conjunctiva. And this pigmentation was not involving the lid margin and the superior pharyngeal region. And these were his examination findings. There was a polypoidal growth on everting the upper eyelid, which was ill-defined. It had a flatter, deeper component. And anteriorly, you could make out that there was slight indentation over the skin. And apart from that, over the lower palpebral conjunctiva also, there was a small 2x2.2 flat pigmented lesion in the inferior palpebral conjunctiva. The regional lymphadenopathy was nil. Now, as we popularly know that the treatment algorithm involves close follow-up if there is no risk. And in case of a PAM with atypia, usually excision and cryotherapy, as well as certain cases which warrant topical chemotherapy can be done. Now, in our case, we gave this is the plan that we went ahead with: a wide excisional biopsy with a frozen section followed by lid reconstruction. And for the lower eyelid, excision biopsy with cryotherapy was planned. And map biopsy was also done in the same sitting, which noted to be negative. Now, the options that we were considering was either to go in for a conservative management with anterior lamella sparing or a full thickness wide excision biopsy. We went ahead with a full thickness excision because of the kind of risk that this eye possessed, especially because there was also a suspicious lesion in the lower palpebral conjunctiva, and he had come to us within a follow-up of 2 years. So these are certain of his on-table images, and you can see that the previous area of nevus excision, which was over the temporal bulbar conch, was completely fine with the AMG well integrated. So here is the image where both the upper eyelid as well as the inferior eyelid lesions are seen. So now for the upper eyelid management, we went with full thickness excision and frozen section. The margins were sent and it turned out to be negative, and the base was also found to be free of the tumor. So the reconstruction was done with this plan in mind, where for the posterior lamella, we considered putting mucosa which was harvested from the lip, the lower lip. And for the anterior lamella, we considered a Fricke's flap, which was harvested from the left forehead itself. And this was his on-table image, and a tarso was placed. Now for the lower lid, a shave biopsy with cryotherapy was done. And the histopathology revealed that this was a case of conjunctival melanoma, which arose from a pre-existing primary acquired melanosis. So this is his image at post-operative day 1. The vision initially being 6.6 before intervention was 6.8. Sutures were intact, and the central tarso was slightly loosened. And over a period of time, his vision improved. The wound was healthy. There was minimal lag of thalamus. And on the medial part, we can see bunching because of a granuloma formation. So that is why it is extremely important to assess any primary acquired melanosis case, and the cytology should be given more importance, and also based on the morphology of the cells of the nevus. And 94% of them have chance of conversion, and 25% of them become metastatic. So thus it is very important. And so close monitoring of any pigmented lesion is mandatory. And this is a case which is a classic example where the entire spectrum of the lesion, the nevus, a primary acquired melanosis, as well as melanoma, occurred in the same eye, but metachronously. Thank you.
Was a systemic evaluation of this patient done?
It was done, ma'am. It was all within normal limits.
Because that's a very important component of the
reason.
management.
Yes.
The local management you will do, of course, but
Yes.
systematically also you should evaluate the patient.
Yeah, he has also been told about compliance now.
Dr. Akshay has.
Just to add to what Madam said, see, if you see the pooled data of conjunctival melanomas, the KP Kaplan-Meier survival chart for survival at 5 years is somewhere in the range of 50 to 55%.
Yes.
So, and unlike say a uveal melanoma, which usually metastasizes to the liver and the lung, conjunctival melanomas typically metastasize to the brain. So yeah, follow-up is
mandatory.
key. So,
yes.
Is Dr. Parinita Singh? Dr. Himika is next, and then Dr. Prayogshal.
A very good evening to all. I'm Dr. Parinita Singh, and I'm currently practicing oculoplasty in Bangalore. First of all, I would like to thank the organizing team for giving me this opportunity. And the case I am presenting today is called Hidden Behind Innocence. So a 55-year-old female patient presented to me with bilateral painless eyelid swellings for the past 7 years, and it was gradually progressive in nature. So the patient mainly came because in the right eye, she noted a reddish mass, which was the reason she presented to me. So on examination, there were firm subcutaneous nodules felt in both the eye upper lids and in the right eye lower lid. The extraocular movements were normal. And on slit lamp examination, on the right eye, we could see a subcutaneous nodule, pinkish in color, most likely a salmon patch. So an MRI was done and it showed a T1 iso-intense and T2 hyper-intense lesion in both the eyelids, and in the left eye, it was extending into the extracorneal space. So we went ahead with an incisional biopsy from the right eye subconjunctival mass and from the left eye lower lid mass. It showed, the histopathology showed sheets of small uniform mature lymphocytes. It was CD20 positive, BCL2 positive, and CD3 negative. The Ki67 index was 20%. So it was diagnosed as low-grade marginal zone B-cell lymphoma. So a PET scan was done and it showed an standardized uptake value of 3 in the eyelid lesions. And the twist was there was a metabolically active lesion noted in the left breast with an SUV max of 31. So we referred the patient to a hematologist who suggested observation for the eyelid lesions, considering that there was a long-standing history and it was a low-grade malignancy. And also for the breast lump, oncologist did a wide excision and it turned out to be a papillary tumor with focal invasion. It was ERPR positive. So a tumor board decided to give radiation to the breast lesion and to put the patient on hormonal therapy for 10 years. So the patient was followed up every year, and on the 2-year follow-up, the PET scan showed a hypermetabolic left inguinal lymph node. The left inguinal lymph node was also diagnosed as an extracorneal marginal zone lymphoma, for which the hematologist again suggested observation. So what we are dealing with is a non-Hodgkin's lymphoma, B-cell type, and marginal zone variety. Marginal zone lymphomas are the third most common B-cell non-Hodgkin's lymphoma. The etiopathogenesis is chronic antigen stimulation, and there are other subtypes such as nodal and splenic variety. It can be seen in gastric ocular adnexa, salivary glands, skins, conjunctiva, lungs, thyroid glands, and the breast. It is staged 1 to 4 by Lugano classification. So the treatment is depends on the staging, what is the symptom of the tumor, and so basically it can be treated by low dose radiation. Another option, if it is as in our case, it was wait and watch. Next, systemic therapy such as chemotherapy, immunotherapy, radioimmunotherapy, and antibiotic therapy if the antigen is there. So these are my acknowledgements. Thank you.
How long was the follow-up?
So currently, ma'am, right now it is 2 years, ma'am.
There's no increase in the
No.
number of lesions?
No. In fact, when the PET scan was done at 2 years, it showed that it did not pick up any hypermetabolic lesion in the eyelid.
So Parinita, was it like an almost near total excision of the lower eyelid lesion that you did surgically?
Of the lower eyelid, not near, almost near total. And of the subconjunctival mass, I had removed it, considering it was very, very small. But the upper eyelid still had small nodules, which were there actually.
Okay. So, I mean, just to highlight, being in ocular oncology. So I think as an ocular oncologist, you take the decision of management rather than depending upon the hematologist. whenever it's related to ocular adnexia. Related to the eye extramarginal zone lymphoma, we have something called not even low dose radiation, the ultra low dose radiation.
Yes,
If
ma'am,
it is
yes.
extramarginal low grade, we would, as an ocular oncology specialist, we wouldn't want the tumor sitting there and growing. So I think you always have the, upper hand to decide the
Actually,
management.
I went and discussed with the hematologist.
No, you
as
can
to-
talk to the radiotherapist,
yes.
yeah, radiation oncologist. So hematologist is not the person who would, in fact, you systemically evaluate the patient. You send, after that, you send for PET scan. So if there is systemic involvement, then as a treating primary physician and an ocular oncology person, you decide whether you want to send the patient to the hematologist or the radiation oncologist. So if there is a systemic involvement, of course, you need a hematologist being part of your team. And if it's just related to your ocular adnexial structure, you as a person would decide, you want to send the patient to a radiation oncologist.
So, ma'am, had we given radiation, would it have affected, altered the outcome at 2 years?
So the lesion is gone, no, Parinita? But now you're sitting still with the lesion.
No,
Why
means
would you?
we got an inguinal lymph node.
Okay.
So that came out to be again marginal zone lymphoma. So my main concern was had the radiation therapy altered the course of the disease. But as they say that it is just local therapy, it does not alter the course of the disease. That's it.
See, one needs to understand that all segments are important. The very fact that after 2 years an inguinal lymph node has appeared, it means that the disease was there in the body lurking somewhere. So everybody has to be on board. It can't be you treating the patient in a silo or the hematologist, hemato-oncologist or the radiation oncologist. This sort of a case is actually a good case for a tumor board, wherever it is available.
Altering the course of the disease, I'm really not sure, but that means the disease is progressing in the body. So getting control of the eye, being the eye cancer specialist, is always good. You don't want the tumor, yeah.
Yes, sir. Thank you.
Dr. Hemika,
Hello. Yeah. Very interesting case. Was BRCA gene done for this patient? Because lymphoma and breast cancer is and genetic counseling. What was the age of patient?
I'm 55.
Yeah, so that's a young breast cancer. How many have you taken? What was the family history?
There was a positive family history of a malignancy. I'm not sure which one,
So
but
we
there
should be
was.
more
Yes,
sure.
ma'am.
Yeah, so
There
that's
was.
one more aspect we have to look, because not just the patient, but the entire family gets affected when we have the BRCA gene positive.
Yeah,
So,
luckily the papillary carcinoma was detected and wide local excision was done, so she's now
that's
fine.
not the daughters, the sisters.
Yes, ma'am. Yes.
thank you. Next speaker is Dr. Hemika Gupta.
Good evening, respected chairpersons, moderators, and dear organizers. It is really a privilege to be here. यहाँ से करूँ क्या? यहाँ से start करूँ? My name is Himika, and I practice ocular oncology and oculoplasty in Mumbai. And today we'll be discussing some practical problems when we treat patients who are in tribal and tucked away areas. And I always believe that even in Uttarakhand, we have a lot of these small pockets where patients coming for follow-up, coming to us is always a problem. So this is based on my experiences. I did our Uttarakhand project way back in 2018, where we just did eye screenings for kids and some ocular oncology cases, which were in more of the tribal belt of Deccan Plateau. So we'll be seeing 3 patients, tribal patients with periocular masses, where we did a different, management, slightly out of the box. As per epidemiology, 104 million tribal population is the numbers for India, and they are almost geographically isolated. Still, the roads are not good, and there's a major transportation difficulty. they have a fear, they are very skeptical when they come to us. So these are the tucked away areas, and like any other hilly state, we have the same problems. They have a very poor health seeking attitude. Sometimes they feel the illness is due to a spiritual punishment. They favor traditional healers. Transportation is always a problem. And poor follow-up and advanced presentation is the package deal. We'll always get those. So with that background, let us look at these three cases. Now, this 60-year-old man came with he's a farmer, Deccan Plateau, nodular ulcerative mass involving medial canthus and upper lid brow. Very suggestive of basal cell carcinoma, and it has this ulcerative look, but it was bilateral. So we said, okay, let's try and do an incisional biopsy before we plan extensive flaps, because looking at that uncle, we were not sure he's going to come back, take care of his flaps. Histoplasmosis, topical itraconazole, go home. So this was one of the masquerade cases which presented as a BCC, but turned out to be histoplasmosis. Case number 2 was from Chhattisgarh. This boy came with a 10-year-old came with a 2-month history of waxy waning disease, poor LPS action, a bad ptosis, which was embryogenic, poor reliability, poor compliance. We managed imaging, which showed like a diffuse fleshy mass, lymphoproliferative, query inflammatory. So now what do we do? And these were some, the current and some old images on the dad's phone. So we tried a multi-pronged approach because we knew that the follow-up is going to be poor. So apart from the biopsy, apart from the debulking biopsy, we did a blepharoplasty. We obviously removed parts of the tumor, tried to debulk, and we did a tarsofrontalis sling also. So blepharoplasty, debulking, histopathology, and sling. HPE turned out to be lymphangioma. And now when he comes back, this is his picture like 10 days post-op, pretty decent. And now when he comes back, we plan to give him a touch-up of bleomycin intralesionally. The third one was a 4-year-old male, again from tribal belt, presented with a leukocoria, diagnosed to have retinal detachment elsewhere long ago when he was an infant. He was reassured by a retina team elsewhere that he's lost vision, but there's nothing else. And there was no follow-up. He came to us with this full-bone mass, which started from the eye and was going into the orbit. And the imaging was suggestive of orbital retinoblastoma with no intracranial spread, involving the nasal part of the eye and orbit. The other eye was normal. Systemic evaluation, metastatic screen was normal. So as per the AJCC, he was a T4B N0M0. And as per the orbital RB protocol, we gave him systemic chemotherapy, planned exentration and radiation. Now on pathology, they saw cells and sheets and cords, but they didn't see any rosettes. They saw round cell tumor with calcification, but they also saw bony tissue. They asked me that could this be an RMS? I said, no, it came from the eye. And it was too anaplastic. So then we started, looking out for other options. And we also had a second opinion done from Hyderabad. And it showed like the tumor optic nerve was free of tumor. NSC was diffuse. And LIN28 was focal intense, pointing towards the malignant teratoid epithelioma, which we've recently discussed by the previous speakers. 2 pathology teams, if you've read this very famous novel, are still not sure whether this is anaplastic retinoblastoma or a malignant teratoid medulloepithelioma. But we were sure that this child is not going to come for follow-up. So although the role of radiation in this child was questionable, as in if it is RB, we have to radiate. If it is not RB, if it is malignant teratoid medulloepithelioma and we've exentrated with all margins clear, we don't have to radiate, but still we err towards the side of radiation. We've given him all radiation cycles and sent him home, and we hope that he comes back for follow-up. So to conclude, one, what we learned is whenever possible, just do a biopsy, incisional biopsy rather than a full excision. Health outcomes in tribal or tucked away populations are disproportionately poor because of poor follow-up. And the poor follow-up is because of economic and mostly travel logistics. Also, this is a shout out to all those NGOs who kind of finance the child's stay and drugs and medicines and treatment, but there's no support for logistics and transport. So sometimes that becomes a very big challenge. And we have to look at these cases compassionately and use some common sense rather than get irritated. Tumhe bachcha pyara nahi hai kya? Why don't you come for follow-up? So sometimes you have to step into their shoes and then figure out a middle path. And sometimes, use our common sense and our learning and use the tweaking technique. Thank you so much for a patient listening. And these are the famous Chitrakoot waterfalls, which are called the Niagara of India in Chhattisgarh. Please do visit those. Thank you.
Excellent presentation. Thank you so much.
I think you've really highlighted something that is seen in India, rural India. Doesn't even have to be tribal, it's just
Yes.
rural India. They just sometimes cannot manage the logistics. So I think you've done a great job in, trying to make sure that we get the diagnosis, we do the treatment without waiting for the patient to come back.
Thank you.
Excellent, Himika, and the effort of presenting this. One lesson that I learned from which a message to the delegates is the last case where you said that the retina person said, so most of these tumors, when it undergoes necrosis, it can be a thicycle eye.
Yeah, this was not thicycle, but yeah.
Yeah, it could have been thicycle, and probably that point the retina specialist or ophthalmologist felt that it can be observed. So again, coming to the staphyloma case and your case, whenever there is a thicycle eye or a pre-thicycle eye in a child, it's very, very important to do an ultrasound B scan and rule out.
So
a
actually, this
malignancy.
case, I went back to the retina person and I told her, I said, you missed, we thought RB. So then she sent me the ultrasound images back then and she said, madam, it was a funnel shaped RD. We could not see a mass. So that again on retrospect tells us that it was beginning from the ciliary body. So that's what I realized, that the retina person had not missed an RB. It was a ciliary body mass which got missed on a ultrasound, and it just showed a funnel shaped RD. And what that retina person did was reassure the parents, this is a retinal detachment, funnel shape, no visual prognosis, just come for follow up and nothing to be done. But they never came for follow up and then came back with the mass. So yeah, that's important. Thank you.
Very good cases. I just had a point here, since we are coming to this again. Will standoff ultrasound be a good test to do in places where we don't have a UVM? Of course, anterion is there, but if UVM is not there, how good is a standoff ultrasound for ciliary body mass? I don't think it's a very good one, but for gross lesions, maybe. I don't know.
Standoff as in the
So
one
in
with
stand-
immersion, we put a
So we just put a lot of ultrasound gel, and the dead space is occupied
So
by the
there's another technique where you take a glove, another jugaad. Yeah, I could have presented that. You take a glove, put water, and then put it sometime. But like Madam said, the ASOCT is pretty good. But in kids, again, handheld ASOCT is a challenge, and they don't really sit on the machine. So that becomes, yeah, it is a tough one. Thank you.
Hopefully we have a ceasefire from just
ये allow करना है Yeah, in the meanwhile, I thank Vishal and team for this kind invitation. And congratulations, Vishal. The first day you have actually taken it the bar really, really high. And I'm sure the team has really worked hard despite all the, volatility which is going on. And I would consider everyone here in this OPAI the warriors of oculoplasty who really made it despite the difficulty. So it's nice to see all of you amid the tensions. And Akshay just showed that there is a message in Twitter that ceasefire between, so we have a happy news. So we're all safe. Yes, there is a ceasefire between Pakistan and India. कनेक्ट नहीं कर सकते मेरा कनेक्टेड Actually, how did Trump negotiate? So Akshay imitates Trump. Stage show, yeah. Yeah, which is really good news. So we are all going back. I thought I'll stay back for 2-3 days. Sorry. ये भी नहीं हो रहा आ गया ना इसमें इसमें आ गया oh, thank you. All right. Yeah, so thank you, Vishal, and thank you for giving me this opportunity to present this. So there is a reason why I'm presenting this here regarding the treacherous malignancy of the orbit. These are my affiliations and my financial disclosure. Now, why I wanted to highlight this particular topic here, the adenoid cystic carcinoma of the lacrimal gland, especially to advocate for the specialty and for the patients, how the management protocols have changed over the year. And why is adenoid cystic carcinoma considered to be treacherous? It has a high recurrence rate. If it's not treated well, 80%, 80% metastasis, and mortality is also 80% at 15 years. Now, what is the complexity that we deal with is it has a complex regional anatomy as far as, lacrimal gland, the orbit is concerned, the temporal fossa, aggressive behavior of the tumor, perineural infiltration, which can cause to invasion in the surrounding structures, hematogenous and lymphatic spread. Now, this is the case scenario. I just want to share a few experiences and I just want to know from the delegates how you would manage these cases. This patient was sent to me at my setup for an exentration prosthesis, already treated by an head and neck onco team. And well, I just went back. He said he just had a cancer. He was a patient from abroad, an Arabic patient. So when I went back, this was how he presented with a proptosis and a dystopia with a lacrimal gland lesion. They did an incision biopsy, which proved as an adenoid cystic carcinoma. And what was done for this patient was exentration, which was bicoronal, see Akshay, and a bilateral neck dissection. He didn't have any regional lymph node, okay? My heart sank because you all are here. I can see lots of head nodding and sad faces. Yes, I was really, really sad. Seeing that at this point of time, adenoid cystic carcinoma is treated this way. All right, really sad. Going on to a second case. This was seen by an ophthalmologist. This patient presented to me after he had undergone certain management. When he came to me initially, his vision was 6/12.
So what he had undergone was a lacrimal gland incision biopsy. Lacrimal gland ACC was confirmed. He just received an orbital radiotherapy. So he was under the follow-up of the radiation oncologist. All right. And they have been observing him, observation, nothing to be done, etc., etc. And then he presented to me at this point of time where there was still a lot of lesions sitting in the orbit post radiotherapy. I had the fear that it would progress. So I sat with the patient, although this was treated at somewhere else in a good center, that this is how we treat it. You might have to go through the chemotherapy. We have to chemoreduce. There is chance of systemic metastasis. And then he came to me. So there was kind of a doubtful scenario between the parent and the patient, whether they should go ahead for further treatment. He came back after they have decided with a counting finger half meter in the same eye. So I saw him in November, and in January, he came back deciding that they want to go ahead with further treatment where the tumor has already recurred and progressed. So this is how aggressive this tumor is. So I think all of us, I just want to advocate this to the entire gathering here, that we have to really, really take it seriously. So would you do it in a different way in these two patients? How do you treat adenoid cystic carcinoma? And I'm sure all of us come into consensus that you really take it seriously, right? I would have definitely done it different way. So we had looked into this, and this paper has been published. Does multimodal treatment improve eye and life salvage in adenoid cystic carcinoma of the lacrimal gland? My paper was rejected like 5 times. We submitted to different journals, rejected, kept going on. 5th year, it got accepted because still they said there is a controversy because not many people were kind of, agreeing to the fact that multimodal treatment protocol helps. But we had proof. Now, when conventional treatment of lacrimal gland adenoid cystic carcinoma was done, it's very, very clear. Exenteration and radiotherapy alone, the 5-year survival rate was less than 50%. Cranio-orbital resection, extensive resection, total local resection, radiotherapy 68. Local resection, exenteration, radiotherapy 56 survival rate, and exenteration and radiotherapy was 43. And this is from Baskin-Palmer. In fact, from Baskin-Palmer, they also introduced neoadjuvant intra-arterial chemotherapy into these cases, but ultimately they all got exenterated as well. So I was fortunate enough to be part of a project when I was doing my fellowship with Dr. Honavar. And the question that we had was, we had a cohort of good number of cases where the treatment of adenoid cystic carcinoma evolved from, the conventional treatment to getting better and further getting really, really better. So the question was, can we conserve and yet improve life salvage? So what we studied was 3 groups. Group 1, surgery and radiotherapy, what is the outcome? Group 2, then again, adjuvant chemotherapy was added subsequently. And then finally, the protocol that we really, really settled, and which I also practice in my oncology practice, is neoadjuvant chemotherapy, where we chemoreduce. It also takes care of systemic micrometastasis. You do surgery, complete excision, radiotherapy, and adjuvant chemo. So what we have found that the mortality rate, and this was a cohort of 40, and the mortality rate among those patients that we treated was much, much less in group 3, as you can see here, which was 0%. And we could salvage the vision, and we could also salvage the eye. So this is the protocol that we follow if we suspect a lacrimal gland lesion aggressively growing clinically. Go and do an incision biopsy. And then when it's histopathologically confirmed, a neoadjuvant chemotherapy of 3 cycles, complete excision with tumor-free margins. You radiate up to the cavernous sinus, considering the primary presentation, and then adjuvant chemotherapy for 3 cycles. So what we have learned, there is definitely a changing trend, but still the conventional treatment is still going on. Multimodal treatment protocol with chemoreduction, surgical clearance, radiotherapy, and chemotherapy can save more lives, yet conserving the eye and quality of life in these patients. Thank you very much for your patient listening.
Thank you, Feroz. I think that's a paper that is changed the paradigm of management it's difficult to get the data from the kind of paper that you published.
Yeah.
Because for each arm to have the numbers that are high enough to statistically power the study is going to be difficult.
Yeah.
And when you can see that the first arm has such obviously high rates of metastasis and death, then there's no way you would recruit more and more patients in that first arm. You'll have to abandon.
Yeah.
So my question is, notice that the group 2, which is surgery followed by radiation
Radiotherapy and adjuvant chemotherapy.
therapy, had nearly the same rates as metastasis and death. One patient died as compared to none in group 3.
Right, yeah. Nearly, actually.
So
Nearly,
would you think, like say, for example, if someone has gone in and done a near total debulking, do you think then again only then radiation surgery would be enough as compared to adjuvant chemotherapy?
Neoadjuvant, you mean? Addition of neoadjuvant, yeah. Very good question, Akshay. Yeah. So there are situations where you have a small tumor where you can actually, as a surgeon, make sure that you completely excise it. And if you can prove it that the margins are negative, I think it's okay. But well, since I have done this study and I truly believe in this study as far as the outcome is concerned, I go for neoadjuvant chemotherapy. Now, the neoadjuvant chemotherapy, the systemic chemotherapy in adenoid cystic carcinoma, obviously we are getting chemo reduction to get a good excision and margin free. But I believe the micrometastasis is also taken care. Yeah. So instead of adjuvant chemotherapy where you're giving only 3 cycles, so there is a 6 cycle, coverage for these treacherous bad malignancy. So that is why I would still prefer doing that. And most of the time, if you see adenoid cystic carcinoma, it's not diagnosed early, right? It's often big. Yeah.
Most often these adenoid cystic carcinomas have such a small lesion, and the history, if you go into the depth of it, is associated with pain.
Pain, yes. Yeah.
So the very fact that there is pain means that there is a neural spread, means that there is already, even though if you don't see even a microscopic, there is an invasion.
Yes, yes.
And definitely, I mean, there was a time when we did not have this neoadjuvant chemotherapy. I used to remove the periosteum and the local bone. It's not described, but I used to do it.
Right.
Just with this
as
idea
much
that,
as possible if you can save the patient.
Just with the idea that the very fact that pain is a symptom,
right,
means that the lesion is gone beyond its boundaries.
Yes, ma'am. Yeah.
No, but I think your point on the neoadjuvant chemotherapy is really important. One for micrometastasis and the perineural spread. I mean, if you've taken out the tumor, but if there is already perineural spread, it's going to keep spreading. So I think I think it's really important, the neoadjuvant. Is there any role of FNAC in these patients?
Ma'am, no, ma'am. We never do FNAC. Incision biopsy is always better. Yeah, yeah. So it's just a request that this is the current protocol of adenoid cystic carcinoma to save more lives. Yeah, and yet be conservative. Thank you so much.
Thank you. Let us join for the session photograph, and it was the wonderful session that was conducted by all the chairpersons and the speakers. Next, we have a video session, 2 minutes to win.
This bilateral underwent this surgery at ODI Center.
So we'll start with the next session, video session, 2 minutes to win. I take this opportunity to call our senior most ophthalmologist in Dehradun, Uttarakhand, Dr. B.K. Oli sir. Recently, he celebrated his 40th birthday. I don't know the Aadhaar card birthday, but won't reveal it. But as he looks, that's how I'm saying. And he is very enthusiastic, always there for you to help. And he loves oculoplasty. So please start with the presentation, video presentation. Yeah. And I would request Dr. Shalu ma'am, yeah, Dr. Maya Hada, Dr. Abjit Kaur, and Dr. Saurabh Luthra, Dr. Akshay Nair. Chair the session and judge the videos, except for Dr. B.K. Oli sir. He just volunteered to present his case. This is a competitive session, so your cases won't be judged. Yes.
This surgery, which I am going to present, is quite an old but excellent surgery. Gives nice results. Fascinella Servet surgery was evolved before 1960 by Fascinella and Servet. This surgery gives excellent results up to 3 mm of congenital ptosis, bilateral or unilateral, provided LPS function is good. The results are excellent. In past 40 years, 10 aspirants candidates for armed forces were temporarily rejected due to unilateral or bilateral ptosis up to 3 mm. All underwent this surgery at ODI Center. After recovery period of 2 months, all the aspirants candidates got selected in Army and Air Force. Now, steps of surgery, the video is before you. Place a stay suture in upper lid using 2 curved artery forces. Invert the lid to include conjunctiva, 3 mm of tarsa plate, and corresponding molars muscle. The whole of this tissue is cut and removed. Alternatively, you can stitch it first and cut the desired tissue later on. The tarsal edge is stitched by 1.5 metric chromic collagen by interrupted matter sutures. You have to start suturing from outer canthus and come back to outer canthus and place a knot at outer canthus. This way, neither the knot nor the suture irritates the eyeball. The surgery is over. Apply plenty of antibiotic ointment, pad and bandage. Next day, pad is removed. Eye is well lubricated with gel and antibiotic. Discomfort after this surgery and swelling last only for a fortnight. Keep the eye well lubricated during this period. Recently, I operated a 24-year boy 2 months ago. This is video, pre-operative picture and post-operative photos of that patient.
Next video.
We are going to present a video of a case of a dacryocytosine managed with a modified lancet.
Tanvi.
A 5-month-old female presented with left eye epiphora since birth and sudden increase in swelling with pain near medial canthus since 15 days. She was diagnosed with acute dacryocystitis with early preseptal cellulitis in a case of dacryocytosine. Systemic antibiotics were started and endoscopic assisted probing under general anesthesia was advised. Under general anesthesia, lacrimal irrigation was done and duct was found to be obstructed with mucopurulent regurgitation from lacrimal fistula. An endoscopic guided nasolacrimal duct probing was then conducted. Endoscopic assisted probing was done and an expected intranasal cyst was noted in inferior meatus. Intranasal cyst is to be marsupialized. In absence of pediatric size endoscope, adult endoscope wasn't leaving room for conventional instrument like a crescent knife and a sickle blade. Then a 24-gauge needle was modified by bending its tip to shape it into a lancet. It was then introduced into the nasal cavity to marsupialize intranasal cyst. Abscess contents were drained. On repeating lacrimal irrigation, duct patency was established. On postoperative day 7, the child was doing well and inflammation was reduced markedly. At postoperative 1 month, fluorescent dye test was negative and tear film height was symmetrical in both eyes. So a standard endoscope is difficult to manipulate in pediatric nose. Thus a simple yet effective modification, that is a bent 24-gauge needle, helps in navigating through restricted nasal anatomy. Endoscopic visualization is now a gold standard in congenital nasolacrimal duct obstruction management. A modified 24-gauge needle maintains procedural efficacy and safety, offering a pragmatic alternative whenever conventional endoscopic tools proves impractical.
Do you have any question? Or shall we move on to save the time? Yeah. Next presentation, please. This presentation is by Dr. Lakshmi. Dr. Kamna. Nice presentation. Is Dr. Kamna Verma here?
Yes, ma'am. Ma'am, we sterilize both tube and then in a sterile pack we kept. Yes, sir. Yes, sir. Yes. And when did you remove the tube? The tube is like placed there. Sir, after 1 to 2 weeks, if that EMG is stable in the eyelid, then we can remove that. Thank you, sir.
Thank you, Dr. Kamna.
We are reporting a
next video is
case
by Dr.
of
Shalini.
absolute alcohol-induced preseptal cellulitis in a case of evisceration with implant. A 22-year-old male came to us with anterior staphyloma of the right eye. We went ahead with the surgical process of evisceration with 20 number PMMA implant. In post-operative period, he had increasing preseptal cellulitis, though he had got no pain, no vomiting. Patient was quite comfortable. So we visited our surgical recording. We could see that alcohol was used very cautiously and spillover of mixed saline was avoided strictly. Thorough saline was given, although it did happen. So there was no signs of infection in this case. We had added presumptive clindamycin, but we know that it's alcohol-induced inflammation depending upon the signs and symptoms. And it resolved on its own in postoperative follow-up. On day 5, we can see the picture, and later on patient went to his hometown and he sent a selfie. On day 7, lead crease had appeared. So these are the follow-up pictures. On 6th week, we could put a customized ocular prosthesis. After reviewing of literature, we came to know that similar case reports have been reported in literature. Signs of severe tissue inflammation and necrosis post-alcohol use in evisceration cases has been reported. There are two different schools of thought. Some people do use it for denaturing the uveal remnants in evisceration cases. Some don't. In our case, since we had this complication, so post this case, we have stopped using absolute alcohol at all for denaturing the uveal remnants in cases of evisceration. So this is our take-home message.
Yes, Dr. Shalini Sujin. Do we have any question?
So basically the reason why alcohol we use is to prevent that whatever minuscule chance of sympathetic ophthalmia in the other eye, especially for patients who've not had post-surgical or post-traumatic phthisis. That chance of developing sympathetic does exist. So would you be justified in the risk benefit of not using alcohol versus using the alcohol and having that little bit of inflammation which you could control with steroids? I would err on the side of caution of using alcohol and giving a little steroids to reduce the inflammation rather than that small chance of sympathetic ophthalmia.
Next video is by Dr. Banka Megha Ajay.
This video illustrates transconjunctival approach to lower eyelid retractor recession with a scleral graft as spacer under local anesthesia in a 24-year-old male with lower eyelid retraction secondary to thyroid eye disease in its quiescent stage since 18 months. Preoperative MRD2 is 7 mm in the right eye and 5 mm in the left eye. We begin by placing traction sutures with forosil. The palpebral conjunctival incision is marked at 4 mm from the lower eyelid margin at the lower edge of the tarsus using bipolar radiofrequency electrode. Conjunctival incision is made using monopolar radiofrequency electrode. Subconjunctival dissection is begun at the proximal edge and adequate hemostasis is achieved. The lower eyelid retractor is recessed from the lower edge of the tarsus, creating a subconjunctival pocket for the scleral graft. The defect should measure twice the amount of lower lid retraction. A scleral graft is procured preoperatively from the eye bank, which comes as a complete scleral shell. A graft of precise dimensions is prepared. The scleral graft is tucked under the lower conjunctival edge such that the convexity of the graft is aligned with the convexity of the eyelid contour. It is fixed to the lower edge of the defect with 6-vicral sutures and glued to the remaining defect using tissile glue. with care to avoid excess glue leakage from underneath the graft. The foro-silk traction sutures are taped to the forehead to act as reverse crossed sutures for 7 days to avoid excessive eyelid movement during the healing process. At 6 months follow-up, the MRD2 in right eye decreased from 7 mm to 5 mm, giving perfect symmetry. Transconjunctival approach to lower eyelid retraction is a safe and effective technique to ensure excellent aesthetic results with no scarring, functional improvement with no inferior scleral show or lag of thalamus, symblepharon or recurrent.
Is Dr. Megha online?
Management depends
Start with the next page.
on depth of the phonesis, surface loss, and volume loss. In patients with shallow phonics, adequate
This is by
surface and
Dr.
volume,
Ashmita.
a progressively enlarging
Ashmita Alwa.
conformer, pressure expander, and canthal expanders are used. The adequacy of upper phonus is assessed by marking the medial, lateral canthus, and on the line joining them. Another marking is made 12 mm from the lower lid margin, indicating the depth of the lower phonus. Using a blunt-tipped instrument, such as lens spatula, the point is pressed downwards towards the inferior orbital margin. Management
Next video.
Have you walked around all day feeling a strange discomfort in your shoes, as if something is stuck, but there's nothing you can find? Only when you look down and closely inspect, you find a tiny pebble hidden deep within your soul. We had a patient who came to us with a history of trauma and red eye since last 4 days. He visited multiple doctors but had no solution. On examination, his vision was reduced, had granulomatous inflammation, restricted ocular movements, and something hard was palpated. There was something hidden, but nothing could be found. On CT scan, we found an anterior-posterior foreign body between the superior and median orbit. On closer examination, the inner table of the skull along with outer was affected. MRI confirmed the position. Sometimes the cause lies deep within and we just need to look deeper. We decided to surgically explore by removing the granulomatous inflammation and lid crease incision. After removal of the granulomatous inflammation and retracting the orbicularis, we reached the extracorneal space of the orbit, where with gentle removal of the tissues, we found the foreign body in the extracorneal space, and slow removal of the foreign body was done so that no iatrogenic damage to the surrounding structures were caused. 2 large foreign bodies were retrieved from the orbit, and post-operatively in the 3rd day, the patient's vision improved and the granulomatous inflammation resolved. Orbit is a 3-dimensional closed space like 4 walls of the room, and any impact of trauma, we must always rule out a foreign body, and when looking for a foreign body, always inspect the medial, superior, and the retrovulvar spaces of the orbit, and we must always correlate with the site of the trauma. Thank you.
Next presentation.
So, Dr. Isha, very nice video.
Dr. Isha.
As a rule, we always approach the foreign body from the entry wound, which was supposedly from the superior fornix. So why did you go transcutaneously in this particular case? Did you try conjunctival approach?
No, ma'am. We directly went
Because of the
ahead.
large granuloma?
Yes, ma'am. Large granuloma, and also we were suspecting a very large foreign body. So we directly went ahead with the transcutaneous and lid crease incision.
But whenever it is a wooden foreign body or any foreign body, you must have seen a discharge coming from the superior fornix somewhere near the granuloma. It's always good to go through the entry wound. Yes.
How do I do make sure that whole of the foreign body has come out?
So we do a post removal CT scan, but we do after retrieval of the foreign body, we do a post-operative CT scan. But in this, the patient got the CT scans, but we could not upload it here. It was on.
Couple of years back, I did had similar case that intraoperatively I couldn't ensure that whether the wooden foreign body was removed totally or not. Then in next week, I had to go into the surgery, and I removed all the wooden foreign body under the intraoperative ultrasound guide. And that helped me to ensure that everything was.
The wooden foreign bodies are notorious. They tend to disintegrate and migrate over a period of time. So if it was a fresh case and you can see the foreign body was large and came out in toto, then you can be sure. Otherwise, if you are taking it out in pieces and it's a long-standing case, then you may have to re-explore it again and again.
Next video. Thank you. स्टार्टिंग से लगाइए, नाम नहीं आया। गौतम लोकदर्शी। Dr. Gautam here. So we move on to the next case, next video. Dr. Monica Joshi. So we move on to the next presentation. Dr. Prerna. Dr. Prerna is here.
Ophthalmomyositis is an ectoparasitic infestation of ocular structures by larvae of diphtheria flies. It is of three types: externa, interna, and orbital myosis, which is rarest but most severe. Now, predisposing factors include tropical climate, neglected wound, ocular trauma, and malignancy being the most common. Pathogenesis involved is release of proteolytic enzyme by serine proteinases, which lead to digestion of host tissue. For management, mechanical removal of maggots is done by using 4% xylocaine, turpentine oil plus chloroform, doing regular dressing. Now, this is a case of BCC of both eyelid complicated by orbital myosis. For the management, oral ivermectin was given first, then a mechanical removal of maggots was done. After that, oral anti-inflammatory and antibiotics were given to the patient. Along with this, topical imiquimod ointment was also used. Now, this is a case of left side face lower periocular BCC complicated by orbital myosis. This is a case of orbital extension of squamous cell carcinoma of eyelid. And in this, mechanical removal was done. After the, now this is a case of extensive periocular BCC of right eye complicated by orbital myosis. Intralesional bleomycin and topical imiquimod was also given along with mechanical removal. Now this is orbital extension of BCC of eyelid complicated by orbital myosis. This is secondary orbital squamous cell carcinoma complicated by orbital myosis. Now, ivermectin is given prior to surgical debridement as oral single dose of 9 milligram. And orbital myosis can enhance the tumor spread or completely destroy the orbital tissue. So it is very important to take proper preventive steps.
The ivermectin dosage is 9 milligrams.
So, sir, 9 milligram or 200 microgram per kg is used.
Next presentation is by Dr. Farnaz Yazir. Lakshmi. Done. Dr. Lakshmi is there. You want to continue with this? Okay. No, it's playing. She denied us from playing. Now, if she's willing, then we can go ahead.
Yeah, so I've just put up a video of how we, in external DCR, how we take out the intubation tubes. So generally, we take out with the artery forceps. I'm just showing how we pull out with just a large bore suction cannula, which makes it easy to prevent trauma to the nasal epithelium. Thank you.
Completely submitted. So with this, we come to an end of this video session. Thank you all, the judges and the participants who have submitted their work. So we'll have a inaugural ceremony at 7:30 in this hall, Hall A, followed by a gala night, gala dinner. Like not gala exactly, it's a Masuri melodies, and now all the more we have good news that the war has been ceased, so it's a good thing. Yes. We have in-house Donald Trump with us, so he'll confirm it tonight. in his own style.